I'd like to ask Senator Stinner to open on this, please.
Good morning, Senator Coldeman and members of the Appropriations Committee. For the record, my name is John, John Stinner, S-T-I-N-N-E-R, and I represent the 48th District. The purpose of LR 145 is to study the adequacy of current aged and disabled Medicaid waiver assisted living provider rates. That's pretty hard to say at one time, but providers of assisted living services serve an important function in the meeting of the home and community-based care needs of some of the most vulnerable Nebraskans due to age or disability. To continue providing access, the payment rates for these services must be sufficient to cover the cost of care and services required by the participants in the aged and disabled Medicaid waiver program. The Department of Health and Human Services established the initial Medicaid waiver assisted provider rates 30 years ago based on an informal process. No formal rate study has ever been performed, and the only rate changes implemented have been the annual provider rate changes approved by the legislature. It is critical for the legislature as well as providers and consumers to understand if there are Medicaid beneficiaries who do not have access to services and whether it is a result of the current provider payment rates. Reports of Medicaid waiver program participants having difficulty assessing assisted living services and specifically living memory care, especially in certain areas of the state, may indicate a concern with provider rate adequacy. This study acquired data currently gathered by the Division of Medicaid and Long-Term Care of DHHS to examine the adequacy of the current age and disabled Medicaid waiver assisted living provider rates and any needed changes. Following an increase in number of nursing home closures, 33 between 2015 and 19, this committee was very thoughtful in working to address the adequacy of Medicaid rates that contributed to that situation. Today, I'm asking to take a closer look at our assisted living facilities and current Medicaid waiver rate is adequate to sustain statewide access to this level of care. With rising costs and staff shortages, the gap between Medicaid waiver assisted living rate and the cost of care has continued to widen. The testifiers following me will provide additional information. They will highlight the challenges associated with trying to meet the needs of the Nebraskans in their community when the Medicaid waiver payment rate falls far short of their cost and must be supplemented by those paying privately. As the number of Nebraskans diagnosed with Alzheimer's disease continues to increase, they will also discuss the importance of an enhanced Medicaid rate for the assisted living memory care, which would allow those individuals to remain in familiar environments and provide a potential cost savings to the Medicaid budget. As the legislature has done in the past for other services, I ask that you consider the necessity of a rate study to determine appropriate Medicaid rates for assisted living and assisted living memory care, rates that will help sustain access and prepare us to care for our aging population. Thank you, and I would welcome any questions.
So do we have any questions? Will you be staying to close?
I probably will waive closing. Thank you.
All right,
I
thank
may come up and sit and ask questions.
Okay, our first testifier will be Lisa Nielsen from Ray Brown and Associates, Assisted Living Facilities.
Chairman Stinner and Appropriations Committee, good morning. My name is Lisa Nielsen, L-I-S-A-N-I-E-L-S-E-N. I'm a member of the Nebraska Healthcare Association, Reimbursement Committee, and Vice President of Ray Brown and Associates, a development and management company. I've served in the capacity of assisted living owner and administrator since 1988, and our company has helped to develop assisted and independent living and memory care facilities in mostly rural areas of Nebraska. These facilities are primarily owned and operated by individuals who saw a need for assisted living in their communities and invested their own money to make that happen. I'm here today to testify in support of LR 145 and share my experience with the Medicaid Aged and Disabled waiver. Assisted living provides vital services to elderly and disabled individuals. Typical services include private apartment, utilities, maintenance, cable, internet, transportation, 3 meals a day plus snacks, personal toiletry items, social activities, medication administration, intermittent nursing care, assistance in scheduling medical appointments, and personal care 24 hours a day. In addition to all of these services, we provide compassion, and sometimes we are more family than family. All of these services are being provided for the current Medicaid rate of $82.22 a day. It's becoming increasingly more difficult to maintain this level of service, leaving providers with no choice but to severely limit Medicaid admissions. There's currently an urban and a rural assisted living rate. The urban rate is $10 per day higher. Senators, please take into consideration that the assisted living facilities in rural communities are small in nature and therefore have less economies of scale. Most facilities cannot afford to pay health insurance, and this is a tough labor market. We must find ways to be competitive. In the past year, we're realizing significant increases in property insurance due to wind and hail storms. And because of potential COVID claims, we're seeing increases in liability insurance. The increased cost of food and supplies is also significant. And like every business, we're struggling because of staff shortage, especially when certified nurse aides and medication aides can work for agency staffing at $30 an hour. Assisted living facilities cannot compete. A rate study for traditional assisted living is long past due, and it's even more critical that we look at rates needed to provide care for people with dementia. Assisted living memory care facilities are appropriate and desired environments for those living with Alzheimer's and dementia. The home-like nature of a memory care facility helps to ease behaviors and agitation and provides more person-centered and dignified care. A critical component to providing good memory care support is engaging people in activities. When residents develop dementia, they not only lose their sense of personal safety, but they've lost their ability to engage in daily activities. It's crucial that we can support a life with some purposeful activity, and that takes an abundant number of staff. Approximately 1 caregiver to every 5 residents during awake time hours. Staff burnout and staff turnover is more likely than in a traditional assisted living. We need money to recruit and appropriately train individuals to work in these types of facilities. Thank you for your time, and I'm glad to answer any questions that you might have.
Take a question, Senator Dorn.
Can you explain a little bit how someone, I call it maybe falls into the Medicaid versus private pay, or what is the difference, or how does someone become eligible for now under that program?
Sure. People spend their money down to $2,500 in assets, I believe, but the association could get you an exact number on that, but they have to spend their assets.
So basically I call it, they're almost at poverty, or they
Yes.
are at that level, and then
Yes,
and they have to meet certain criteria, or they do not qualify for Medicaid
that's correct.
reimbursement rate.
That's correct.
What happens if they don't qualify for a Medicaid reimbursement rate? Then it's a different rate,
Well,
approximately how much higher?
that's gets very complicated. Then, they aren't able to move into a facility. If they don't qualify for Medicaid, they don't have enough money to pay privately, then they're probably just trying to manage in the community without services.
Okay,
And
thank you.
sometimes that happens to people, even if they have long-term care insurance, it might not be enough to cover the rate for assisted living.
Thank you.
Senator Coulterman.
Thank you, Senator Stinner. Thanks for coming today. I have a question. You talked earlier about the fact that Medicaid reimbursement is $82.22 a day, and is that the one for the urban senators?
That's for
Or
rural.
for urban? That's rural?
That's the rural rate.
So urban is $10 higher?
Yes,
And then that's for Medicaid
correct.
reimbursement. What is it if I'm a private pay and I want to come into your facilities, what would that run?
It just depends on the facility. All facilities have different rates.
Approximately how much higher would it be for private pay versus what we're reimbursing? Medicaid.
Maybe $15 to $20 per day more, depending on the room size that you would choose. It's just depends on so many
Right,
different
obviously, if
factors.
you're private pay, you've got a lot more options available to you.
True.
So if, I guess the question where I'm going with this is, I'll go a different direction. What percentage of population is Medicaid versus private pay in your facilities?
Right now, I would say average 12% Medicaid versus private pay. It's been higher, but right now I would say in the facilities that I help operate, it's about 12%.
So you only take about 12% of the population for Medicaid.
We have taken more in the past.
Okay, so most years is private pay, then, is what
Yes,
you're telling
it
us.
is. Yes.
Okay,
And for someone needing memory care services, none of those residents are Medicaid.
they're all private pay.
They have to be, they have to be private pay.
And memory care, they get the same reimbursement rate of 92.22 in a urban setting versus 82.22 in a rural setting.
Correct.
So that's for 24-hour day.
Yes, it is.
Okay, thank you.
Yes.
Additional questions? Seeing none, thank you.
Our next testifier will be Amy Middleton from Good Samaritan Society. Welcome.
Good morning. For the record, my name is Amy Middleton, AIMEE-MIDDLETON. I appreciate the opportunity to be able to testify and provide you with some information. So thank you for allowing us to be here today and provide some information. I serve as the Nebraska Healthcare Association Treasurer for the association, and I also work for the Good Samaritan Society as the Executive Director of Operations, serving the state of Nebraska. I have 31 facilities in Nebraska, 15 of them being skilled nursing facilities and 16 being assisted living facilities. I serve primarily facilities that have a very rural footprint. A couple of you have facilities in your district, so I appreciate you serving them as well. In our facilities, I have about 50% Medicaid and 50% private pay. I serve over 100 Nebraskans on Medicaid in our facilities. We are a large member of our communities, being in a rural area. Sometimes we are one of the largest providers, and I have both a skilled nursing facility and an assisted living facility in that community. Most of our facilities were built as part of a grant around 30 years ago or so. Some might remember where there was a large need to have an additional level of care. So our assisted living facilities were built about that time, serving a great need, and we've served that need over the last 30 years. But reimbursement has not followed the increase of care and the increase in cost. It is just like in our skilled nursing facilities, sister facilities, the individuals that are coming and needing care today look very different than they did 30 years ago. People are staying home longer, as they should stay in their homes as long as they possibly can. But what that means is when they come to be a part of our community, they are needing a lot more care, which does require more staff, which, as you're aware, and I know you'll hear some testimony today on workforce, is becoming increasingly difficult. We have a need to serve the population that is in our area. When we have a facility in an area and a population that is needing something, they're not looking to drive 2 hours away to choose a facility for that. They want the facility in their community where their loved ones live, where their grandchildren are, so that they can come and see them. So in rural areas, we don't have the opportunity to really balance that payer mix. We really have to serve the community that is presented and needing care at that time. That becomes increasingly difficult when we're looking at a referral that is needing Medicaid and we already have 75%, for instance, in a building, 75% Medicaid. Taking an additional Medicaid resident, we are taking on essentially additional costs. So I'm adding another resident and adding another $631 on average per month loss to take that resident and serve that need. So that makes it very challenging to balance that. I would also say that an incredible part of the cost of care is staffing. So if I'm making that decision and I'm deciding whether or not to bring a resident in or not, I also have to evaluate, am I going to have to bring in additional staff? That comes at an incredible cost. If, for instance, and many of these assisted livings are small 12-bed buildings. So if I'm sitting at 7 residents and I'm going up to 8, I might need to add an additional staff member, which really is incredible. And I might have to add that person 24 hours. Memory support adds an entire new level. If I have a resident referral that I'm looking at that suffers from memory loss and we know might not remember or might think it's a great idea to go outside in the middle of the night in our lovely Nebraska winters when it's 30 degrees outside. And so that cost of that care comes at a high cost. We would look at deciding to put in a Wonder Guard system. It's a bracelet system that would alarm at the doors to the cost of about $30,000 to $40,000, depending on how many doors we have. When I look at the decision and the losses that we're looking at over this year, it's very hard to decide. My SNF, my skilled nursing facility might be really losing. It's impossible to keep that assisted living open if the skilled nursing has to close. I mentioned the $630 per month per resident that we do lose on a Medicaid resident. I also wanted to just, for my 16 facilities, we are averaging $56,000 loss per month and projected this year $672,000 to give you an idea of the gravity of the loss. I would really ask that you support this study to help us to continue to be able to provide the care to these Nebraskans that I do believe is so very important and needed in all of our communities.
Additional questions?
Yes.
Senator Clements.
Thank you, Mr. Chairman. Thank you, Ms. Middleton. I was wondering if you have closed any facilities in the last 5 years?
In the last 5 years, yes. We have closed from the Good Samaritan Society, I believe 3. I've been in this role for 2 years, so it would have been my predecessor, but I believe they closed 3 facilities. It would have been skilled nursing and assisted living. And I would say that I have a few that are at risk currently.
All right, thank you.
So if we do this study, what's it going to say cost-wise, urban versus rural? And I'm just going to preface that. There seems to be a myth that it costs less to run a facility in rural Nebraska than urban, and I think it should be the other way. Because I see a lack of skilled nursing. I've been in a lot of these assisted living facilities, and they actually have to hire nurses from outside who have to travel and so on and so forth, which adds to their cost. Anyhow,
I would agree with you that that is a myth, that it costs less. I think it costs the same, if not more, in the rural areas for the exact same reasons that you stated. Staffing is extremely difficult. I have a facility, for instance, in Valentine, Nebraska. There is not a Walmart within 2 hours. My pitch is that there's a Dollar General in town, and it's almost the same, but reality is very hard to get a traveler to come in, and they have a severe workforce shortage. So to get a traveler to come in, I am paying 2 times more than I am in Omaha to get someone to go to Valentine, Nebraska. And there's not any housing, so then I'm paying an additional amount in mileage for them to travel from a neighboring town.
do you have a feel for how many Medicaid qualified people that can't get access to assisted living? What that census would look like if we tried to?
I don't have exact numbers, but I know Cindy Kennedy is going to testify after me. She might be more appropriate to have a better idea of that.
Additional questions, Senator Colterman.
Thank you, Senator Skinner. Again, thank you for being here. A couple of things caught my attention. You have 31 facilities throughout the state, and how many are in dual? So you have maybe one assisted living in a community as well as as a,
Yeah, almost all of mine are dual in our communities where we operate both. I do have a couple where we've closed the skilled nursing facility and have been able to keep the assisted living open, but I would say that they are at risk now, and it's very challenging.
is the bulk of your, are the bulk of your facilities in rural or are they in urban settings?
Most in rural. I don't have any in Omaha or Lincoln, so I would consider almost all of them rural. One in Kearney and one in Grand Island, a little more urban.
And then you talk about you're losing 631, correct me if I'm wrong. I thought I heard you say you're losing $631 a month for every Medicaid patient that you take,
Correct.
and you're going to lose approximately $672,000.
That is what I
year.
project to lose on our Medicaid residents alone.
So on just your Medicaid residents. So private pay has to pick up some of that.
Private pay
They're
residents.
subsidizing the Medicaid.
Yep.
And then I guess my last part of this is, since you're known as a Good Samaritan Society, I assume that philanthropists are picking up the difference so you can keep your doors open?
We're a non-for-profit organization, and I would say we balance our portfolio in certain different areas. And so we might have a larger facility in a community that can serve more private pay, and I balance that in my portfolio. So some facilities I know I will have a loss, and other facilities I might have a profit, and it will balance out to be able to continue to serve in those communities.
How much philanthropy, what percentage of philanthropy helps you pick that up, other than just the cost shift from private to Medicaid?
I wouldn't have an exact number on that, but we do have some wonderful community members that do donate.
All right, thank you.
Senator Dorn.
Thank you, Chairman Stinner, and thank you for being here today. So what happens when a community or we don't have facilities for the Medicaid people? What happens to those people? Where do they end up?
Yeah, so I can give you a pretty good example. I have a facility where we had to make a really tough decision, but we're 75% Medicaid. We couldn't take another loss in that facility. They're driving over 2 hours for care today.
So they're driving to another facility that maybe will take them. So do any of them, I call it, just fall through the cracks then? Do we have people out there in Nebraska that are not being able to be served anywhere, or last resort family, or what happens?
I would say that's who they are being served by, and I would say they are falling through the cracks. You have a dual income family. You can't just stop working to care for your loved one. So I would say there definitely are some that are falling through the cracks that then can't get admitted in their area, but family doesn't want to move them 2 hours away. And so they are missing on that needed care.
Thank you.
Additional questions? Seeing none, thank you.
Thank you.
Lois Jordan is our next testifier.
Good morning. Thank you for
Morning.
having me. Good morning, Chairman Stinner and members of the Appropriations Committee. My name is Lois Jordan, LoisJordan. I'm the president and CEO for Midwest Geriatrics in Omaha, Nebraska, and I'm here representing Leading Age Nebraska. I serve as the past president for Leading Age. Thank you for the opportunity to testify on LR 145. Midwest Geriatrics provides assisted living services for 95 to 100 seniors in Nebraska, and more than 80% of those individuals we serve are eligible for Medicaid waiver. With the shortfall in Medicaid waiver reimbursement that fails to meet the actual costs, we operate with a very thin margin, if any margin at all, some years. Our ability to sustain our operations is dependent on closely managing our payer mix amongst our resident population. For assisted living, the two primary payer sources are private pay and those who have spent down their resources and are eligible for Medicaid waiver. As you've heard today, Medicaid waiver rates were established more than 30 years ago using an informal process. No formal rate study has been done to date. Rate adjustments over the years since its inception have not kept up with the cost of providing care. As a result, assisted living providers limit the number of individuals they can serve whose primary payer is Medicaid waiver. The shortfall is more pronounced for assisted living memory care services due to the higher staff to resident ratio. Despite the necessity for additional staff to ensure resident safety, assisted living memory care communities are paid the same rate as traditional assisted living. For example, traditional assisted living may have one staff member for every 15 residents. Memory care assisted living, by comparison, will have one staff member for every 5 residents. Our average cost of care, and this is our cost of care for traditional assisted living, is approximately $3,000 a month. Our average cost to provide memory care in memory care assisted living is approximately $4,475 a month. Medicaid waiver reimburses us $2,087 a month. Room and board are paid directly by the resident at $730 a month. So the total amount we receive for assisted living services provided to individuals on Medicaid waiver each month is $2,817. This results in a shortfall of $1,658 per resident per month. And it is the primary reason many providers choose not to serve Medicaid waiver assisted living memory care. Our Nebraska seniors deserve unrestricted access to assisted living services, including memory care when they need it. It is my hope that passing LR 145 and conducting a study of the aged and disabled Medicaid waiver rates would result in rectifying the payment disparity for assisted living providers and thereby result in improved access to care for seniors needing assisted living care, and specifically those needing memory support. I'm here to testify in support of LR 145. Thank you.
Thank you. Questions? Senator Colterman?
Thank you, Senator. Senator, thank you for coming today. My question deals with, you talk about payer mix.
Mhm.
So you decide what percent of Medicaid you accept and what percent you don't accept.
Correct.
When a person enters into your facility, people generally are not aware of who's on Medicaid and who's not. Is that accurate?
That's accurate.
And you don't discriminate about what kind of care you give somebody versus Medicaid versus
We do
private
not.
pay.
We do not.
And what percent did you say was your Medicaid rate?
80% of our residents in assisted living. Mhm.
Wow.
And if an individual comes in and is spending down their resources and needs to apply for Medicaid, we don't ask them to leave. There are some facilities that will need to because they aren't able to manage that payer mix.
Because of the mix.
Right, and so that becomes a challenge for access for those individuals who don't have a year or more in private pay funds.
All right, thank you very much.
Thank you.
Additional questions? Seeing none, thank you.
Thank you.
Our last testifier will be Cindy Codby.
Good morning, Chairman Stinner and members of the Appropriations Committee. My name is Cindy Cadavy, CINDY-KADAVY, and I'm here on behalf of Nebraska Healthcare Association and our 238 proprietary and nonprofit assisted living communities across the state. In asking Senator Stinner to take a closer look at the current Medicaid waiver rates paid for assisted living services, we considered several factors, most of which are outlined or illustrated on your handout. Since 2015, there have been 23 closures of Nebraska's assisted living communities. We know that the demographics of our state are also changing. Our population is aging. Older Nebraskans are more likely to live alone without a live-in caregiver, and the incidence of Alzheimer's is projected to increase. And this data supports the need to plan ahead. As you've heard, the Medicaid waiver rates for assisted living facilities were established when the program began in 1991. And the director at the time called a couple of providers, talked to the associations, and established those rates. And as also has been said, the only increases since that time have been those approved by the legislature. So as a result, the gap between the waiver rate and the cost of care has increasingly widened, and you'll see an illustration in their handout. A small survey of assisted living providers indicate the Medicaid waiver rate falls short of the cost of care by about $1,000 to $2,000 a month, although it differs by the region of the state that you're in. And although 75% of our assisted living facilities participate in the Medicaid waiver program, many of them have to establish limitations on the number of individuals they can serve that are reliant on the Medicaid payer. So currently, our assisted living communities have the capacity to serve over 13,000 Nebraskans. But as of July, according to Medicaid, the number of Medicaid waiver participants was approximately a tenth of that number, around 1,750. When it comes to assisted living memory care, as you've heard, the gap between the rate and the cost of care is even wider. The same survey of providers indicates that the cost of memory care in assisted living exceeds the rate by about $3,000 to $4,000 a month. Although once again, it depends on the region. And as you've also heard, in many areas of the state, it isn't even possible to access assisted living memory care if you are a Medicaid beneficiary. And that for that individual, what that means is sometimes leaving a familiar environment because your only option may be to go into a nursing facility. And which also leads to, logically, it would seem like there could be a Medicaid cost savings. If Medicaid would pay a higher rate for assisted living memory care, then the individual could remain in that facility and not need to move to a nursing facility, especially if they don't need 24-hour nursing care. There's really no reason, and it would be at a higher cost to the Medicaid program. So as you've heard, we're asking for your support for legislation next session that would require an assisted living rate study. And should the department say they don't have the resources to conduct such a study, we'd hope that you would consider appropriating funding. As it would be a Medicaid rate study, the department would be able to claim 50% federal match for the cost. To give you an idea of what a study might cost, a couple of years ago, I talked to UNL's Bureau of Business Research about a much broader study, and they estimated the total cost would be around $200,000. Just to give you an example, so with the federal match, that would be about $100,000. So I did want to explain too, just a question came up during earlier testimony. To be a participant on the Medicaid waiver program, you first qualify for Medicaid, which is dependent on your amount of resources and your income. To qualify for the Medicaid waiver program that will pay for assisted living, you have to meet nursing facility level of care, which means that your needs have to be high enough that Medicaid would pay for you to be in a nursing home. So what that means is those individuals, not only is the pay lower than the private pay, but their needs are often higher than those paying privately. So thank you for your time. I'm glad to answer any questions.
Thank you. Questions? Senator Coleman.
Thank you, Senator. Cindy, thank you for being here. My question is going to probe a little bit into, there's a distinct difference between assisted living versus custodial care, which you'd get in a nursing facility. So when I used to be in that business of selling policies, you assumed that a nursing facility was more expensive overall than an assisted living facility. And what I'm hearing today is the mix is, roughly $5,000 for assisted living per month.
Mm.
And so how much is there a big difference between that and regular nursing or full custodial care in a nursing home?
Do you mean, Senator, what somebody would pay privately or through private insurance
No,
in a nursing home?
just a general rate difference between a regular nursing home versus a custodial care in an assisted living facility.
Okay. So the Medicaid rate or the cost?
Cost.
The cost. Okay, so the cost in the nursing home would typically be a lot more because they're required to have 24-hour nurses on staff on site. They're required to meet a number of other criteria including having an RN available 8 hours a day, 7 days a week. So that drives up the cost in a nursing facility. In assisted living, some assisted living facilities they're not required to have a nurse on staff. Now, some do, but they're not required to. So they do have to have a nurse oversee the medication administration. So some assisted living facilities might have a nurse consultant. For both types of facilities, the main cost is staff. So that's why the nursing facility, there's other reasons, but that's one reason the nursing facility would cost more.
What I'm trying to get at, I think, is it's just so people understand the difference here. If you're in custodial care, which I consider full nursing facility, is there a rate? The Medicaid reimbursement rate, is that different for that than an assisted living Medicaid reimbursement rate?
Yeah,
And how much difference would there be there?
Okay, and that's a really good question. So Medicaid pays for nursing facility care. There is a facility-specific base rate, and then that's adjusted for 34 to 34 levels of payment based on the acuity of the individual. So individuals in nursing homes that need more care, Medicaid will pay higher than they would for somebody who doesn't need as much care. In assisted living, it's one rate.
So in assisted living, we don't discriminate. We just say we're going to pay you $82.22
Correct.
a day, period.
Correct.
Even
Yeah.
if they're memory care assisted living?
Correct. Yeah, there's just one rate.
Okay, thank you.
Additional questions? I just would have one, just a general question to you. COVID's had an impact, severe impact on nursing homes, certainly, and assisted living. What's this current census look like? Are you down 10%, 20%, or?
So census in assisted living has gone down because of COVID and people staying at home just because of some of the lockdowns that are, I guess they're called lockdowns, but where they have to have quarantine. So I can get you more exact numbers on both nursing homes and assisted living, but there definitely has been a drop in census. And on the nursing facility side, they're seeing a little bit of an uptick, but not necessarily on assisted living.
I'd be interested in those numbers for this
Okay.
session, plus whatever you project to see your census coming back, because the direct impact of vacancies and cost associated with that, I think we need to take a pretty hard look at from our side of things. So,
Yeah, glad to get you that information.
all right, thank you very much. That concludes our testimony concerning LR 145. I do waive my closing comments. We will now open with LR 209. Senator McDonald.
Thank you, Chairperson, Senator. Good morning, members of the Appropriations Committee. My name is Mike McDonald, spelled MIKEMCDONNELL. I represent the LD Legislative District 5, South Omaha. This study shall look at the criteria related, let me start over. Today I bring LR 209 to examine the necessary appropriations necessary to create public health crisis zones for certain areas in Nebraska. This study shall look at the criteria related to public health, behavioral health, poverty, substance abuse rates, and any other relevant criteria that could be included in a public health crisis zone program. A public crisis health zone would require an accountability system to be put in place to determine baseline public health metrics. These metrics could include a number of specific benchmarks regarding appropriate public categories, including but not limited to behavioral health, rates of infectious disease, mortality rates, substance abuse statistics, and other benchmarks. These benchmarks should be combined annually by census tracts to create healthcare zones and rate these scores across the state. Zones that score high as having a disproportionate amount of health issues would be classified and reported to the governor. Director of Department of Health and Human Services, and to the Clerk of the Legislature, annually on or before December 31st of each calendar year. Areas scoring high can be designated public health crisis zones and shall remain public health crisis zones until such designation is removed by the governor. The purpose of this is to see if the statutes and the funding applicable to the natural disasters could be used as a framework to move resources more effectively to improve health outcomes in targeted districts. We want to look at how we would provide funding and support to local public health departments, counties, municipalities, and other entities that would play a role in implementing partnerships to develop a public health crisis zone. In 2016, when I decided to run for the legislature, I had a friend of mine that approached me, and she told me her story about her father and what happened at White Clay and that area of our state. And it wasn't only that he was suffering from alcoholism, but that it was all the surrounding. It was that synergistic effect. It was the idea that it was the poverty, the alcoholism, the lack of hope. And when you look at that, I think we can all look at our districts and look at an area where you look out your front door, you look across the street, you look right, you look left, and you see nothing but people that are struggling in different areas. And with that thought, as the state of Nebraska, I believe we need to shine the light on those areas. And it's to say to the local community at that county level, at that city level, at that village level, to say, here, at this point, we're here to help you. And we want to assist you. We're not trying to tell you how to solve your problem, but we have resources that you do not have. And also the idea that we have to have a plan. And it has to be looked at least annually on how we are solving that problem. So that problem just doesn't continue to spread. There's people out there that want help. There's people out there that don't understand how to get that help. There's people in government that are serving in different areas of the government that don't know all of the opportunities for the people they're trying to help. With trying to create these zones, we know they exist. And we know that in that certain area, people are coming together based on poverty, based on a number of the social ills that we all face. And they're not getting the help they need. And at this point, possibly, if we looked at them as a neighborhood and as we could come in there and try to do A to Z, or at least make sure people understand the different areas that we could try to help possibly their neighbors struggling with a different problem. But when she explained that to me and said, it wasn't so much about my father was drinking himself to death. It was also the point where wherever he looked, other people were struggling and there was no hope. And at this point, I think we could look at a statute working together with the governor and all departments of the state of Nebraska and their local governments, that we could really have an opportunity to look at these areas with a critical eye and a helpful eye and bring all our resources together, just like we would in a natural disaster. We have two people that are going to testify today that I've invited. Tara Ewing with Three Rivers Health. Tim Bennock is an Omaha firefighter that has dealt with poverty when he makes calls on a daily basis. And he's currently working on his capstone project for his master's public administration program at the University of Nebraska at Omaha. So those are the two people I've asked to testify today. I will be here to close. Thank you.
Any questions? Senator Clement.
Thank you, Mr. Chairman. Thank you, Senator McDonald. What this sounds like, why isn't this before the HHS committee instead of appropriations?
Because it costs a lot of money. That's what it comes down to. You know, everybody wants to talk about solving problems, and I agree that they are definitely, that's why I mentioned it in my testimony with HHS. But the idea that we as appropriations, they're going to come back to us. And at this point, also, Senator, to be real direct, I sit on this committee. And I wanted to be here, and I want to talk about money, because money's going to help us solve the problems. I'm not saying money solves all our problems. I'm not saying that if you give people a dollar that they always spend it in the correct manner, but I'm saying most of our problems, most of the solutions, if we give people the opportunity to run their race, to remove these unfair hurdles that are sometimes there, it's going to cost us money.
And who's going to declare the crisis?
That's what we would be developing through this LR and looking at when we introduce the bill in January. That's what we're trying to develop. The idea of having the governor at that level at some point would be able to stop that and say, you know, at this point, they've hit the criteria. But the subject matter experts that we're going to be working with, the idea of trying to look at where does that finally, is there a category of 20 things that if you look at teenage pregnancy and you look at unemployment and you look at alcoholism, you start adding these things up, at some point there's a tipping point. And there's these things that are going on where we need to address. And I'd rather have it more of, we're looking at different areas that create that zone. And now as the state government, the county government, all the way down to the local government, we're trying to work together to solve those, but we have to have a plan. What is that plan? Just like if we had a natural disaster, we are going to come together quickly with our resources and we're going to develop a plan of action and how to help those people.
Okay, thank you.
Additional questions? Seeing none, thank you. Our first testifier is Terry Ewing.
Good morning,
Morning.
Chairman Stinner and members of the Appropriations Committee. My name is Tara Ewing. That is Terra Uwing. And I am the Health Director at the Three Rivers Public Health Department based out of Fremont. I am here today to testify in regard to LR 209 on behalf of Friends of Public Health here in Nebraska. We are grateful for Senator McDonald for introducing this study and thinking proactively on an issue like this. I am also grateful to the committee for your time today. This past year has been trying and quite frankly has taught all of us about crisis and emergency response. I plan on listing a few specific local examples from across the state on what could possibly be eligible or defined as a public health crisis zone. In the Three Rivers Health District, the most recent and relevant example is the Mead ethanol plant public health crisis and the response that has been needed from our health district. Scientists are investigating the contamination of water, soil, and air caused by a closed ethanol plant. Toxic piles of ethanol byproduct called wet cake are rotting on the grounds of the plant near Mead, Nebraska, and a stench permeates the area. Snow and rain send chemical-laden runoff into waterways, contaminating groundwater and drinking water. In dry weather, the wind kicks up toxic dust that has been linked to public health issues and local residents. This response has included scientists from UNMC, UNL, and Creighton, Saunders County Medical Center, county supervisors, Senator Bosselman, community members, local businesses, just to name a few. It became apparent early on in this response that this was a statewide response and that resources would be needed to address the public health crisis. The remediation will take time, expert guidance, and financial resources. Other areas around the state that have experienced complex public health emergencies that also may fit within this study. Some public health crises are environmental and require a long-term response, such as Mead, the plumes in York, or White Clay. Others are related to infectious diseases such as the avian flu or tuberculosis, and those examples may also fit within this interim study. We understand that this is a study, and if the committee moves forward with a proposal like this, our local public health departments would like to be included on the crafting of that proposal. We do think that starting from a framework similar to natural disaster declaration has merit. However, we think that there are district differences between public health emergencies and natural disasters. We would be happy to help assist on potential definitions and ensuring that potential legislation is narrowly crafted. As you might expect, if there are additional duties added through the creation of public health crisis zones, we would request that there be a funding mechanism in place for local public health departments and other community partners who assist in the response effort. I think that is why we are in front of the appropriations committees today, but I would like to make sure that we make that point. We are thankful to the Appropriations Committee and the legislature for your support of local health departments in the past few years and stand committed to working with all of you. Thank you for your time today and for your partnership with public health.
Thank you. Questions? Senator
Yeah.
Dorn.
Currently, under today's whatever we do, and we don't have this crisis management type zone for Meade, how is that handled? Is that handled by basically the public health or the state, or as you mentioned, all these other entities?
So since we don't have the public health crisis zones and we don't have the funding for it, what has happened is there was some money that was donated by somebody out of Omaha to start the remediation or the study on this in Meade. So that's how this has been crafted and put together. So they are looking to try to find additional funding to continue the study because it's going to take several years.
Additional questions? Seeing none, thank you.
Thank you for your time today.
Next testifier will be Tim Bernack. Benak.
Thank you, Chairman Stinner and members of the Appropriations Committee for hearing me today. My name is Timothy Benak. It's TIMOTHYBENAK. I am here today to show my support for LR 209. Currently a student at UNO for my master's degree in public administration and an Omaha firefighter, I chose to concentrate on this resolution for my final capstone project. I decided this is my focus because creating public health crisis zones in Nebraska, it's a rather revolutionary idea, and I think it has the potential for tremendous benefits to the long-term health of Nebraskans. Through initial research, it has become evident that Nebraska lacks a standardized reporting system for identifying public health threats, and it lacks the ability to empower and hold localities accountable. In 2016, a policy brief that came out of UNMC's Center for Public Policy, it looked at criteria by which a governor may declare a public health emergency. While this study focused on statutory language in the Emergency Management Act, it was important because it found that Nebraska lacked language and it varied from at least 34 other states in identifying, defining, or declaring public health crises. The resolution presented today has the potential to not only correct this language, but also to provide a unique framework in which Nebraska can quickly identify and mitigate a variety of public health threats. I'm here to answer any questions and thank you for your time.
Thank you. Questions? Seeing none, thank you for your service,
you.
by the way. Senator McDonald.
Thank you. Again, we're looking for ideas. We're looking at working on this until January. We know there's clearly a problem, and there's, I think, a number of ways to possibly look at this and find a solution that can work for all of the Nebraskans that are struggling for the future.
Senator Coulterman.
Senator McDonald, thanks for bringing this today. I guess my question kind of goes back to what Senator Clements was asking earlier on, and I understand the value of being here. Would you say that this resolution is more than anything to call attention to the fact that our public health departments have been underfunded and they're not given the legitimacy that they might need to carry out some of the roles that they're playing?
I definitely believe there's that funding issue, but there's also that coordination issue and that idea of that sense of urgency issue, where comparing it to a natural disaster, you have that focus, laser focus, and you have all these people coming together to help. So I definitely think there's a funding issue and a coordination issue, and then a sense of urgency issue.
Mr. Chairman.
Senator Clements.
Thank you, Mr. McDonald. Mr. Bennick talked about, I think he mentioned there's a lack of authority. Are you going to propose that someone else besides the governor has the authority to declare an emergency and require, say, masks, and where the governor would not be able to overrule that?
No, I think you're looking at a criteria that would have to be developed through the legislative bill, through statute, that says it's this point, when this area hits X number of these type of problems, that we step in, work with the local government, have that annual report. Not saying that it's not anything they could do right now on their own, but trying to coordinate them together and then make sure that we have that annual report of saying, okay, what is our progress? Did we take a step forward this year or a step backwards? So it's not the ability with my thoughts, and before I developed the legislation, that's what this LR is for, is to try to look at, okay, at some point, we'd like to have the governor have the ability to say, you know what, we had this problem, we had this zone, and now X number of years later, you really look at those criteria that we would develop. They have now exceeded, and they are no longer in that crisis. And the governor at that point would say, based on this criteria that would be in the statute, they're no longer in crisis.
Thank you.
Senator Coulterman.
Thank you again, Senator Stinner. So when you decided to bring this and you look at the natural disaster types of declarations that happen, when something like that occurs, the governor has the ability to say it's a natural disaster, and that automatically opens up potential federal funds if they can get grants from the federal government. Would the same type of thing occur here? Do you know if there's any monies available through the federal government for healthcare disasters?
Using the comparison with the natural disasters is based on when you look at a tragedy and all the great people that step forward to help, people want to help. And the idea of having that laser focus and so many agencies working together is more of the goal than the idea that if we have a situation where does it open up federal funding, I don't know. That would be something that I can research before January. But it's more of the idea that these natural disasters happen and you have all these great people step forward. We have these crises, we're in crisis right now in a lot of areas of our state, and we're not focused on it like we would a natural disaster with all of our resources. And that's more of the point, is to bring everyone together, keep the public light on that area to help, but then also on an annual basis to make sure we measure our progress. But if there's a way and a thought that you have to tie it into potential federal money to help, and because I think that's possible right now, that we could be missing just by not communicating with the different agencies from the state down to the local agencies, again, trying to work together. And I've seen that as my career on the fire department. You get a number of things that happen and people come together so quickly, but a number of times people don't know what, the old saying, what the right hand is doing, what the left hand's doing. They don't coordinate as well.
So the Meade situation that we have, where we have a lot of contamination going on, and the public health department has stepped in and they've found some people to fund that. Could we be looking at something similar to that? When we have old gas stations, as an example, there's a super fund that can be attached to clean up some of that contamination. Is that the type of thing you're looking for here?
If you're looking at different type of templates, yeah, we're looking at the idea of what's happening at a Superfund site with possibly contamination of groundwater. We have a situation right now where we have looking at it in my perspective, a Superfund site of human beings that we are not laser focused on with all of our resources and coordinating on how we can help them. And it's growing. And it's in that area where, again, when you start looking at different areas of poverty, all the different problems. And again, there's an old saying that success breeds success. Well, failure breeds failure. And if that's where you look, and again, looking out your door, east, west, north, south, and you're seeing nothing but failure around you, it doesn't give you a lot of hope. And so I know we have resources. I know we have people that are passionate, that care. We have people in the private sector. We have people in the philanthropic community that care, trying to get people focused. But also, I think everyone gets busy and everyone has their lives, and people work hard and they get tired. And then all of a sudden we get moving on to something else. But to force us to come back and have that annual report card to say, how are we doing in this part of the state, in this neighborhood? How much have we helped from the state on down, and possibly, as you're suggesting, possibly with federal funds?
Senator Vargas.
Thank you, Senator McDonald. I don't know if you thought about this. I'd be most interested in your and your thoughts, and if you don't have an answer, that's okay too. This differentiation between a public health emergency being defined separate from a natural disaster. I think about this because how you're thinking about establishing the criteria, because looking at it, I mean, behavioral health, poverty, there's a lot more that we can see in terms of health inequities, access inequities along lines of race and class and zip code and housing. So I didn't know if that's also playing into what we would define as a public health emergency, if you've thought about that, or if those been conversations with public health departments, because need is a great example of something that is very apparent. There's going to be a public health component, but outside of that, I'm thinking we have substandard housing issues very clearly delineated in East Omaha, in our districts, right, and in North Omaha. And we can create a very clear demarcation between housing and health and public health. I don't know if that's something that you've talked about or you're planning on sort of establishing, more clear.
So the thought and trying to compare and look at how we respond to a natural disaster, that's more in the sense of that we are laser focused on it. We bring all our resources together and we're prepared. Everyone knows, I mean, you don't know exactly what the natural disaster is going to be, but you know what your resources are and you coordinate. And then afterwards you grade it. Now, trying to look at that, take that off the table for a second, but try to get that kind of laser focus. And we have a list of possibly 30 things that would meet this crisis zone. And again, it's could be housing, it could be in there. It's unemployment, it's teenage pregnancy. There's a number of things that are going to combine to come together, and they're not always going to be the same. A lot of them are going to overlap, but that's going to create that crisis zone. And I believe that's something that we should try to do. Now, trying to research this, I don't know if anybody in the country is doing this. I mean, it's always nice, don't be too proud to steal a good idea. If someone else is doing it, I'd love to be able to grab their template. I just don't know if anybody's done this in the country. So it's making it, again, a little bit more difficult, but it's definitely worth our time and our effort to try to develop something like this. But I don't want to get too caught up in the idea of the natural disaster. The reason I'm bringing that up is it brings everyone together and it brings our resources together.
Okay, thank you. Any additional questions? Seeing none, thank you. That concludes our hearing on LR 209. Do you have your stuff for LR?
Yeah, I'm ready.
Okay. We'll now open on LR 212.
Thank you, Chairperson Sinner, members of the Appropriations Committee. My name is Mike McDonald, MIKEMCDONNELL. I represent Legislative District 5, South Omaha. Today, I bring LR 212 to assess the healthcare workforce shortage in Nebraska. As you know, we are dealing with a healthcare workforce shortage in Nebraska prior to COVID-19, a situation that has only gotten worse with the pandemic. First responders in our healthcare workforce have been dealing with compassionate fatigue, burnout, and even PTSD. We currently have a severe shortage in all areas of healthcare all across our state, and perhaps one way we can help alleviate this is by increasing funding to the loan repayment program and expanding eligibility. We can also do what some other states have done, such as Minnesota and North Dakota, and offer incentives for current healthcare workers to act as preceptors for students in Nebraska-based healthcare educational institutions by focusing on the healthcare pipeline, starting with health science programs in our state and creating additional capacity throughout the state. We may be able to turn around this dire workforce shortage. The purpose of the study is to hear testimony on the needs of the industry with focus on nursing and entry-level healthcare support positions, such as medical technicians and certified nursing assistants. This study will analyze the state and local funding opportunities, policies, and initiatives to address the shortage and to meet with and anticipate Nebraska's growing healthcare needs. The study shall further examine how to increase opportunities for all Nebraskans to enter into and advance in these healthcare professions, align and expand education and training and strengthen the capacity of diversity, well-being and retention of the healthcare workforce. I have a number of people that are going to testify today, and when they started reaching out and talking about their situation and as subject matter experts, I thought it was important. And I ask you for your patience. There is going to be 11 people that are going to testify today, but they are our subject matter experts. And this is such, we are at a level at this point that's dire. And I think we have to focus on it. And of course, as you all always do, you listen to the people that come in front of you. But I thought it was important for all 11 of them to testify today, but I ask you for your patience.
Thank you. Any questions? Seeing none, our first testifier will be Nebraska firefighters, Darren.
Gary.
I'm not attempting last names. Darren. I've already failed that already.
Good morning. My name is Darren Garian, D-A-R-R-E-N, last name G-A-R-R-E-A-N. I'm president of the Nebraska Professional Firefighter Association, representing about 1,500 paid firefighters and paramedics across Nebraska. And I'm here in support of this LR. And many people don't necessarily recognize firefighters, paramedics in the healthcare, but they are huge in the pre-hospital setting. And we go out and we usually are the first interaction with the patient before they get transported to a hospital. Some of the things that we've done over the last couple of years in recognition of some problems are there's a burnout issue, there is a compassion fatigue issue, and there's a recruitment and retention issue. Those are some things that have just continued to be red flags for us all the time. And some of the things that we're looking at trying to adjust is specifically Senator Tom Brewer's LB 963 was a resiliency training program that we set up in conjunction with Nebraska Center for Workforce Development. And what that is to go out to the first responders and basically teach them how to be resilient to all of the bad stuff that happens around them. Be more resilient to the things that they see every day, be more resilient to the situation. What that does, it helps them at home, it helps them in their work life, and hopefully some of that resilience keeps them on the job and from quitting or from doing bad things. We were just in your neck of the woods talking with some of the first responders that had a suicide. And from that, and I apologize, from that though is going to come some training that's going to come to you from this specifically. The other thing that I have been working on is with other first responders on recruitment retention with law enforcement, and there is a substantial diminishing interest in doing the first responder work. And this has been a trend, and we're looking collaboratively to see what we can do to increase basically the recruitment aspect of it, but keeping people on the job from leaving. There's been a mass exodus of people just not wanting to do it anymore. With that, I've been working with a healthcare group in specifically doing an annual healthcare screening that would be encompassing of a cancer, cardiac, and mental health care assessment of the individual. And I realize that's specific to maybe a firefighter or a paramedic, but I bring this up for knowledge that this is something that is completely scalable. And the importance of that is on the healthcare side of things, if there are red flags that we can see maybe triggers, let's get somebody in to see some help before things become a problem. For a firefighter that may have a cancer diagnosis, let's go in and get some treatment before it becomes catastrophic. These are some preventative things that we hope will be help in some retention and also keep people working longer. So with that, I'll answer any questions. I'm here to help.
Okay, questions? Seeing none, thank you.
Thank you.
Okay, our next one is Nebraska Center for Nursing presentation on data of nursing shortage. I do not have a name, but I presume you will check in. Good morning.
Good morning, Senator Stinner, and thank you for allowing me to testify today and the rest of the committee. We appreciate your attention to this important issue. My name is Lisa Walters, LISA-WALTERS. I'm the chair of the Center for Nursing. While I am employed full-time by the University of Nebraska Med Center College of Nursing, my testimony today is that of the Center for Nursing. I was appointed by the governor to the center in 2014, and I've served as the chair for the last 4 years. The data reported in this testimony comes from the Nebraska Center for Nursing Workforce Data Report. A copy has been provided to each of the committee members. The Center for Nursing was created through statute of the Nebraska Legislature in 2000. The statute outlines goals which address monitoring nursing supply and demand, as well as issues related to promotion, retention, recruitment, and the utilization of nurses. The Center for Nursing is funded through a percentage of nursing licensure fees. The Center for Nursing has the only data bank of licensed nurses in the state of Nebraska. We collect information on all licensed nurses based on the National Workforce Minimum Data Set. This data is collected biannually. However, due to the pandemic, an executive order has deferred the licensing renewal of RNs, delaying the ability to have current RN data. All licensed nurses, LPNs, RN, and advanced practice nurses will be renewed by October 31st, 2021. After that date, the center will have the most up-to-date information on all nurses licensed in our state. There are approximately 28,000 RNs who have already relicensed, and that's out of about 30,000. The Center for Nursing Workforce Data does not include information on unlicensed or nursing-assisted personnel. In Nebraska today, 63% of registered nurses are located in urban areas, 29% in urban clusters like Grand Island, Kearney, Scottsbluff, and Norfolk. And only 8% of RNs are in rural areas. 11 of the counties in Nebraska don't have an RN. In Nebraska today, the average age of RNs in Nebraska is 44. The national average is 51. 1/4 of the RNs in Nebraska are millennials, which is 36 years of age and younger, and 1/4 of our nursing workforce is over 55, which is about 6,000 RNs. So as those nurses begin to retire, we are going to have a hard time replacing them. Another force driving demand is that in 2020, for the first time in our state's history, the proportion of the population over the age of 75 exceeded that of the population under the age of 5. As we get older, we generally have more healthcare needs, as you heard earlier in testimony, due to the aging and the development of chronic illnesses, increasing the need for nursing care. Nebraska's supply and demand model was developed and implemented in 2018. The model incorporates age, gender, and the degree of urbanization of our state population, the healthcare settings required by the populations, and the number of nursing full-time equivalents, or FTEs, required in each of those healthcare settings. The projected shortage of FTEs by 2025 is 5,436 for all licensed nurses. Looking at the data by economic regions, 70% of the total shortage will be in the Omaha and Lincoln regions. Rural regions have unique challenges, however, when they're confronted with nursing shortages, especially surrounding recruitment and retention. Data collected in this report is pre-pandemic. The data that we analyze after October 31st will allow us to be able to compare our pre-pandemic numbers to the post-pandemic, hopefully post-pandemic. According to 2021, Nursing Solutions Incorporated National Healthcare Retention an RN staffing report, the year 2020 recorded the highest nationwide RN turnover rate in the past 10 years. In 2020, the national turnover rate was 19%, while in 2019, it was 16%. The numbers in 2021 continue to rise. One of the most disturbing aspects of the bedside shortage is that 25% of nurses leave their employment within the first year of their employment. The last reported turnover rates for Nebraska hospitals was 13.4%, recorded in 2017. According to the NSI report, the estimated average turnover cost of a staff nurse is well over $40,000, with an average today of at least 89 days to replace that nurse. In 2021, NSI surveyed 1,500 nurses. 94% of nurses reported some form of burnout, and 10% talked about planning to leave the profession. A link to that report is provided to you in my testimony. So what are the recommendations? We need to stop the bleed. Healthcare facilities need to reduce the turnover, improve the workplace culture, support and recognize the professional nursing workforce that they have. Nurses are creative and outcome focused. They can be a part of the solution. The question is how the workforce feels about bonuses offered to new employees, travelers, and mandatory overtime. The solution is focusing on what will retain nurses in their current role. Mental health support for healthcare workers, as you just heard, is also critical. The pandemic has raised the level and intensity of healthcare worker stress. An existing program like the Critical Incident Stress Management Program that is currently provided primarily for EMS could greatly benefit healthcare workers in all settings. Expanding and funding critical incident stress debriefing teams to support frontline workers during traumatic or stressful situations can decrease the long-term negative effects and build resiliency. For more information on our Nebraska Center for Nursing website, you can find the unabridged data. And I thank you for your time today and your willingness to serve and to look at this important issue. I'll take any questions.
Thank you very much. Questions, Senator Clement?
Thank you, Mr. Chairman. Thank you, Ms. Walters. I've heard about vaccine mandates by hospitals, and we're already short of nurses. What do you think that's going to do to the shortage? Do you have a percentage, do you think, that's going to be terminated?
I can't speak for exactly what everybody's hospital policies will be, but I do believe that we probably have lost workforce because of the pandemic in terms of people getting COVID, the fear they have of spreading it to their families. Vaccination is one way to ensure that you probably will not be hospitalized, that you will have a mild case of the disease if you do contract it. It's science. It protects all of us. And in my opinion, it's a way to curb the pandemic. There may be some people who do not feel the vaccine is right for them. And that's a personal choice they will have to make. But it could impact our workforce also.
And was there a problem with nurses contracting COVID before the vaccine as they worked in the hospitals?
That I don't have a number on. So anecdotally, I can't speak to that right now.
All right, thank you.
One of the things, and I've spent quite a little bit of time looking at this. We have a nursing school in Scottsbluff. It always seems that we don't have enough clinicals, so we can't increase the class size. Is there any movement or any ideas about how we can do that so that we can get more folks through the schooling piece and the clinical?
Thank you for recognizing that. And I believe our other testimonies will speak to that in more detail. But being in healthcare education myself, I know that that is an extra burden on an already overstressed staff nurse to have a student to oversee and to be a preceptor for. So we're always grateful when we have clinical sites who are willing to take our students, but it is an additional stress, and we recognize that.
Thank you. Additional questions, Senator Vargas?
Thank you very much for being here. I had a question. It's helpful to get the national data. And so 2000, the Nebraska Center for Nursing was created in legislation. And I looked at the data from 2017. So the RN turnover rates, that's the most up-to-date data we have from 2017.
It is. And I know that there are hospitals who track their own turnover, whether it's by unit or for their whole facility. So combining that into a statewide number would be helpful.
And I didn't know if there was anything within the statute for the creation of the Nebraska Center for Nursing that, we're looking at child and maternal mortality. It's another bill, an interim study I'm working on. Since we don't have up-to-date data, it's really hard for us to be nimble and see if what we're doing locally at the state level is working. And so part of the question I have is there something we can do, legislation or directly through NCN to make sure we have more up-to-date data to see movement in the right direction or in the wrong direction? Because 2017 is a long time ago.
And I think working with our healthcare associations, we can ask to try to get that kind of information.
Yeah. Well, that's where we got the data last time. So that's from a consultant group. So, I just think more up-to-date data will be really, really helpful because this 25% number at the national level is really concerning of nurses leaving within their first year of employment. Do you know if that's within the first year of employment and going to another job in nursing or leaving the profession altogether?
The turnover rate is leaving your employment. So at that point, we are guessing that they're going for other jobs within healthcare.
Okay. Thank you very much.
Thank you.
Additional questions? Seeing none, thank you.
Thank you. Appreciate your time.
Our next testifier is Dean Sebastian from UNMC College of Nursing.
Good
morning.
Good morning, Chairman Stinner and members of the Appropriations Committee. Thank you for the opportunity to provide testimony related to LR 212. I am Julianne Sebastian, Juliann Sebastian, and I'm Dean of the University of Nebraska Medical Center College of Nursing. My focus will be primarily on the need for nurses and entry-level healthcare providers today, but I will also address to some extent more broadly the need for the full range of health professionals. Despite the growth in many health professions in Nebraska, disruptive shortages continue to grow as demand increases. Rural areas experience a disproportionate impact of shortages. For example, although the total number of physicians has increased, 14 of Nebraska's 93 counties are classified as federally designated shortage areas for one or more primary care specialties. Access to behavioral health providers is a serious issue, with 91 Nebraska counties classified in whole or in part as federal mental health shortage areas. Nebraska's supply of nurses has increased over the past 2 decades, but the shortage of nurses is growing as demand outstrips supply. The COVID-19 pandemic has worsened the trend, with health professionals reporting exhaustion and burnout. The need is growing for entry-level healthcare workers as well, whether to assist health professionals with tasks that can be delegated or to provide care for vulnerable populations, such as older adults or people with disabilities. Throughout the summer, Nebraska hospital administrators have reported that care is being delayed, not because of lack of equipment or beds, but instead because of inadequate numbers of nurses, respiratory therapists, and other health professionals. As you know, the governor declared a hospital staffing emergency on August 26th and issued an executive order that waived some licensing requirements for many health professions. The governor also issued a directed health measure that began on August 30th, eliminating elective surgical procedures in hospitals. Imagine if you or a loved one needed a procedure that was determined to be elective. That care, which you may not feel would be optional, would be delayed with no clear date when you might receive the procedure. Key considerations in healthcare workforce include the extent to which the workforce reflects the population of the state and the needs of today's highly acute and complex patients. With nearly 22% of Nebraska's population reported to be racial or ethnic minorities, and none of the health professions groups that reflect that demographic composition, there is work to be done. The National Academy of Medicine recommended that 80% of the nursing workforce hold a baccalaureate or higher degree. Nebraska has made progress in this direction, with 67.6% of registered nurses holding a baccalaureate or higher degree, but we are still far short of that goal. In terms of pathway programs, the University of Nebraska Medical Center has partnered with the Nebraska State College System on the Rural Health Opportunities programs since the early 90s. The Kearney Health Opportunities Program and the Urban Health at UNK and the Urban Health Opportunities Program at UNO built on these successful pathway models. The High School Alliance at UNMC is a program affiliated with Metro Omaha Public School Districts that introduces high school students to health careers and helps prepare them with meaningful learning experiences in science. Pathway programs have the potential to expand health professions education in rural and underserved areas and to encourage students from diverse backgrounds to consider health careers. A key issue in planning for further expansion of the health professions workforce, which you mentioned earlier, is access to clinical learning sites. Simulations can help by better preparing students for work with real patients. Preceptors and clinical agencies indicate the need to be compensated for the time required to support student learning. Tax credits have been used by some states to address this issue. Other challenges relate to having sufficient funding to hire additional faculty and staff, providing housing for students completing clinical rotations, competitive salaries, sufficient space and technology to support contemporary learning, and crucially, expanded funding for student scholarships. In closing, I would like to thank Senator Stinner and each of you for the opportunity to testify about the critical impact of shortages in the healthcare workforce in Nebraska, and I'm happy to respond to questions.
Questions? Seeing none, thank you.
Thank you very much.
Our next testifier is Nebraska Hospital Association. I don't have a name, but
Good morning, Chairman Stinner, members of the Appropriations Committee. I am Andy Hale, A-N-D-Y-H-A-L-E, and I am Vice President of Advocacy for the Nebraska Hospital Association. We'd like to thank you for this opportunity to present this testimony in support of LR 212. Nebraska will have a workforce shortage of just about 5,400 nurses by 2025. 73 out of Nebraska's 93 counties have a lower than national average ratio of registered nurses to patients. 66 of Nebraska counties have been deemed medically underserved. 9 counties in Nebraska have no registered nurses, and 4 counties have just 1 registered nurse. Workforce shortages were always a big concern for hospitals and have only become more exacerbated by the pandemic. It's no longer a problem down the road, it is a problem now. And it's not just a problem during the pandemic, as 90% of nursing leaders surveyed recently identified staffing shortages and retention as a growing concern post-pandemic. And the concern is not only in rural parts of the state, the Omaha and Lincoln areas will represent 70% of the total nursing shortages in the state. When you have a nursing shortage, it affects both Nebraska's physical health and economic health. Lack of care impedes the ability of communities throughout the state to draw and hold local residents and businesses that employ them. As Lisa mentioned before, this is the first time in the history of our state that the population of individuals 75 years and older now exceed the individuals who are 5 years and younger. And by 2040, that number is expected to increase by over 100,000 individuals. And 3 out of the 4 people older than the age of 65 have multiple chronic diseases which require more difficult degree of care. It's not just hiring a workforce, it's retaining a workforce. When we talk about our members or talk to our members about their two biggest concerns, staffing shortages and burnouts. 94% of RNs indicated some degree of burnout. And in 2020, we recorded the highest RN turnover rate in the last 10 years. To help address this issue, the Nebraska Hospital Association formed a nursing shortage working group consisting of nursing leaders, deans of nursing, HR leaders, state nursing board members, other association members, and the Department of Labor. We begin meeting on a monthly basis. We started in July, and we plan to bring official recommendations to this legislature and to the state in early December. Some ideas that we are considering are some ideas that you've heard earlier today and yesterday as well during the ARPA money. Senator McDonald brought up using loan repayment programs and scholarships. This is a bill that Senator Stinner brought last year. We would like to increase that funding and increase the participants of those who can be eligible for those. Investing time and money in early intervention programs like HOSA and others throughout the state. Invest money in resiliency and retention programs. Additional funding in nursing instructors, clinical instructors, and increases in clinical space. Incentives for nurses professionals to continue their education. Remove scope of practice barriers, and explore opportunities to invest in private and public partnerships. The NHA wants to thank Senator McDonald and his staff for bringing this issue to the attention of the legislature, and the NHA looks forward to working with all of you on addressing this issue.
Questions?
Yeah.
Senator Dorn.
Thank you, Chairman Senator. Thank you for being here today. Earlier there, you commented about that real high level of burnout or whatever. What exactly are they telling you?
Well, what we're hearing is, initially in the pandemic, there was a lot of, I guess, respect and commercials and those things for nursing. You saw it on TV, you saw it wherever, and that kind of has waned as this pandemic has gone on. And so you're looking at, do they feel appreciated? Do they feel worth? At times you've had individuals outside protesting, whether it's masking or now with the vaccine mandate. You're looking at, this pandemic. I don't think anyone thought that this was going to last. And so as this continues to go, so does the rate of burnout. And it's really appreciation, understanding of it. We looked at some studies that, sure, salaries are important and increasing wages, but as far as retention goes, it's being respected, being appreciated, those sorts of things.
Thank you.
I do have a question. Since you're with the Hospital Association, I would presume that you have taken a look across the state at, just where we are with the healthcare professionals as it relates to doctors on down. I think it was several years ago, I looked at a study that says the state of Nebraska per capita has the most hospitals, or the second most behind Texas. So we got all these critical access hospitals across the state, and a lot of them are within 15, 20, 30 miles of each other. How do we continue to staff those with professionals, or do we start to look at, or has your association looked at, maybe we reduce some of the critical access hospitals down to more of a clinical status as opposed to a
actual critical hospital. I know for a lot of small towns, that's, it's almost like a mortal sin type of thing, but
Yeah,
but the reality is we can't produce enough professionals to staff them.
yeah, staffing is really the big question when it comes to that. What we're exploring is the rural emergency health model, which is converting a critical access hospital to an emergency department only and then performing outpatient services. And so that is a bill that has been passed on the federal level. There's probably some legislation that we'd have to bring here to the state to bring it in, but we're looking at it. A hospital in Kansas, rural Kansas, has kind of been the project program that we're following. And so it is something that's interesting, but it's difficult to have those conversations with your town, because you are going to probably be losing your workforce for that's already there by doing that. And there's some angst of having to go further for those sorts of things. But those are conversations we're having, especially with those hospitals that are in those areas that you described.
I'd like to see some of that information.
Absolutely.
I presume the committee people would as well. Senator Clements, do you have a question?
Yeah, thank you, Mr. Chairman. Thank you, Mr. Hale. I'm going to repeat my question. The employee vaccine mandate seems odd to me with already having shortages. How do you justify that?
Well, we've always had a stance of everyone that who is eligible and appropriate in a healthcare setting should be able to get the vaccine. The frustration that we're hearing right now from our members is lack of details. The White House has put OSHA in charge of this, and then CMS will be enforcing it. And we haven't seen any of the details. So we don't know what the exemptions are going to look like, whether those medical or religious. For those that do have exemptions, we don't know how often they're going to be tested. Is the employee going to pay for that? Is the hospital going to pay for that? Is the federal government going to pay for it? There is a hospital in the southwest part of the state that has about 300 employees. They are very concerned that they could lose up to 10% of their overall workforce. And so that is a question they'd like to answer. I mean, they looked at one of their entire departments they would have to shut down. And so you've reached a level of individuals that probably aren't going to be vaccinated. At this hospital, I think their vaccination rate was about 70%, which in my opinion is probably pretty good for a critical access hospital in a rural part of the state. But their town has a vaccination rate of about 40%. So if they lose that workforce, where are those individuals going to go? And this just isn't just for travelers. Travelers can, nurses, physicians, techs. This is line staff as well. And so these are areas that they would have to consider shuttering temporarily or asking for the state or the National Guard to come in to assist with that. So they are very concerned about the vaccine mandate. But again, Senator, right now our biggest frustration is the lack of details. We'll have a call Friday with our federal delegation that the NHA is hosting with our members to kind of let them be aware of this situation, that we need more details, and then kind of shine the light on this workforce issue is what's going to happen.
Thank you.
Additional questions? Seeing none, thank you.
Thank you, Senator. Thank you.
Next testifier is Tim Platt, Chief Nursing Officer, CHI. Morning.
Good morning, Mr. Chair and members of the Appropriations Committee. My name is Tim Plant, Plante. I'm the Division Vice President of Nursing for CHI Health. CHI Health is a regional health network consisting of 14 hospitals, 2 standalone behavioral health facilities, and more than 150 employed physician practice locations and 10,000 employees in Nebraska and Southwest Iowa, serving communities from Corning, Iowa to Kearney, Nebraska. I appreciate the opportunity to speak with you today regarding the healthcare workforce shortage in Nebraska, and I want to thank Senator McDonald for providing this forum. But I am here today to sound the alarm. The healthcare workforce in Nebraska and nursing in particular is in crisis. I'm not one to use that term lightly, but I do want to communicate the urgency of this issue to the committee today. As you know, CHI Health participated in yesterday's hearing before this committee regarding the state of Nebraska's plan to allocate American Rescue Plan Act funds. Workforce shortages were a common thread amongst almost every testifier in every industry. And why we believe that is true and are supportive of the many suggestions and initiatives proposed to address this issue, we do believe that nursing and related fields need to be prioritized given the extreme pressure our healthcare systems are experiencing and the extreme pressure our employees are experiencing as a result of the COVID-19 pandemic. CHI Health alone could hire over 750 registered nurses tomorrow if we could find them, and closer to 1,000 positions when we include related job classifications in the nursing profession. And while our hospital system is experiencing negative financial impacts from the COVID-19 pandemic and designated health measures such as limiting elective surgeries, it's this workforce shortage that is by far the biggest challenge to our system and therefore the biggest challenge to providing needed care to the citizens of our state. This is why we are working with a coalition of healthcare interests to request approximately $80 million in ARPA funds for tools that we think can be helpful, such as 5-year retention bonus contracts, scholarships and loan forgiveness within state work requirements, and graduate medical expansion grants targeting the nursing workforce. At a time when traveling nurse companies are paying nurses $200 an hour to provide care elsewhere, this is needed just to stay competitive and to maintain our current numbers. Without the ability to retain our current employees and attract new employees, hospital capacity will decrease and units will close out of necessity at a time when we need all of the capacity and resources that we can muster. None of these proposals seek to recreate the wheel. In many cases, they can supplement current programs such as Nebraska Loan Repayment Program that repays student loans for physicians located in rural areas. Should such a program be extended to registered nurses, certified nursing assistants, licensed practical nurses, and medical assistants in rural and urban settings, for example, we estimate we could have 5,000 employees interested in pursuing it. And while we know this hearing isn't regulatory in nature, I do want to express concern about the role of nurse staffing companies that are playing in this situation. Without a large number of new nurses in our state or any kind of incentive for our current staff members to stay, nurse staffing companies are able to offer wages at levels that are unsustainable for any health system and result in net losses to our nursing pool, as many have elected and elect to leave the state for months at a time to earn very high salaries. And while we don't assign blame to the staffing companies for seeking profits or to nurses taking advantage of the demand for their work, this only results in churn and unpredictability in our workforce during an already difficult time. Many states, in fact, have started price gouging inquiries into such companies for charging such high rates during a public health emergency. These services currently are costing CHI Health approximately $4.5 million a month, which is unsustainable and is not the long-term answer. I appreciate the legislature's interest in these issues and for hearing me out today. I'm hopeful the state ARPA funds provide a one-time opportunity to help get us through this crisis, but realizing the need is immediate, I'd encourage the state of Nebraska to consider what can be done in this critical interim timeframe as well. We stand ready to work with you, our healthcare partners, and all Nebraska employers to address these issues that we all know are key to getting through the pandemic and to the future success of our state. Thank you for your service, and I'd be pleased to answer any questions.
Any questions? Seeing none, thank you. Next testifier is Nebraska Medicine.
Still morning, right? Good morning.
Good morning. Yes,
Chairman
it is.
Stinner and members of the Appropriations Committee, thank you for allowing me a few minutes to address LR 212. I am Suzanne Nuss, Suzanne Nuss. I'm the Chief Nursing Officer for Nebraska Medicine in Omaha. I am testifying today to support an interim study to assess the healthcare workforce shortage in Nebraska. I'd like to start by thanking Dr. Sebastian and Ms. Walters for setting the stage for my testimony. They provided a high-level overview of the problem. I would like to share concerns and experiences specifically related to Nebraska Medicine. We have seen several changes when comparing fiscal year 19 to fiscal year 21. In fiscal year 19, the average daily adult census at Nebraska Medicine was 481. In August of this year, the average daily census was 536.
This is an increase of 11.4%. The case mix index, which is used to measure the complexity and severity of patients, has increased 12.8%. We've seen an increased need for registered nurses of 148 FTEs and an increased need for nursing assistants of 64 FTEs. Results from an internal survey of nurses conducted in January of this year identified that nearly 75% of our nurses reported they will no longer be in this role in 5 years, and 79% reported they are experiencing symptoms of burnout, compassion fatigue, or both. In fiscal year 21, we had 102 nurses resign within the first year of hire. This is a 36.6% turnover rate and is an almost 15% increase in first-year turnover compared to the prior year. It's estimated that the cost for replacing a nurse is about $50,000. So the cost for us to replace those 102 nurses who left in the first year would be $55 million. These data points demonstrate that we have less nurses and less nursing assistants caring for a higher volume and a higher acuity of patients than pre-pandemic. That these nurses are so burned out that they plan to leave their role within a few years. It also reveals that we have a major challenge retaining nurses, especially in the first year, and replacement of these nurses is costly. At Nebraska Medicine, we conduct exit interviews with nurses who leave the organization. We started this at the beginning of the pandemic when we started to see an increasing number of nurses resigning. These interviews identified a major theme of nurses leaving for travel nurse positions. Many stated they had always thought of traveling and that the stress of the pandemic led them to moving up their timeline. Most of the nurses leaving for traveling are younger and do not yet have family commitments keeping them in Nebraska. They often state, and I quote, "It's a good time for me to see other parts of the country." As the pandemic has continued, the themes from these interviews has changed. More recently, nurses are leaving for Monday through Friday positions in clinics or surgical centers, and unfortunately, a handful are leaving healthcare altogether. For those who continue to leave for traveling, the reason has changed. Due to our staffing shortages, which has impacted nurse-to-patient ratios, they are now reporting, and I quote, "If I have to have these higher ratios, I may as well do so for 3 times the salary." We realize there's not an easy fix or quick fix for this critical staffing shortage. Consequently, we are investigating and are implementing several alternative care models. Over the past 6 months, we've introduced paramedics into our acute care teams. This is a role new for this setting, but so far the model's been successful. The paramedics enjoy the work and the RNs appreciate team members that can assist with different tasks than nursing assistants. We're also piloting a 1-to-1 RN to nursing assistant model for more efficient care of patients. And the intent of both of these models is to allow the teams to more safely stretch assignments to care for more patients. We're also examining how to include LPNs and virtual nurses into the care team. The rate limiting factor for all these care delivery models is lack of availability of workforce. As a more immediate solution, we have hired travel nurses. We are currently paying $175 per hour per nurse, and we currently have 50 travelers at Nebraska Medicine. While travel nurses do fill a void, they are expensive, as Mr. Plant just said. In addition, when we have travelers, we often see an exodus of nurses when we hear the perks of traveling. We have also instituted mandatory overtime for all RNs. They are required to work 1 additional 12-hour shift per 4-week pay period. Finally, we offer a $30 an hour bonus for nurses who pick up an additional shift beyond their scheduled and mandatory overtime shift. Despite these initiatives, we are still experiencing short staffing on a regular basis. For example, in July and August, we averaged a 7.4% RN shortage on our inpatient units. With the average daily census of 536, that means we had about 40 patients per day who we cared for outside of our defined staffing plan. To address future needs, Nebraska Medicine continues partnering with Clarkson College and UNMC College of Nursing to identify pathways to increase enrollment for undergraduate and RN to BSN programs. Challenges to these programs include a lack of sufficient number of faculty and clinical experience locations. As the chief nurse for almost 3,000 nurses, I have grave concerns about the safety of our patients and our workforce if we cannot find a solution to the healthcare staffing shortage. I am proud that we have not experienced a major patient safety incident as a result of the staffing shortage, but I am concerned that it could simply just be a matter of time. Our staff are weary and struggling to see a light at the end of the tunnel. In conclusion, as you can see, these challenges are significant and require urgent action by the state. I would recommend the committee and the legislature please consider Immediate investment to preserve our current nursing workforce by using American Recovery Act funds to establish retention incentives over the next 4 years. Recovery Act funds should also be invested in loan forgiveness for nursing students coming out of school and scholarships to community colleges and bachelor's programs to incentivize all levels of nursing profession. Long-term, the state needs to increase its ongoing funding commitment to nursing education. Our educational programs need sufficient funds to hire additional faculty and staff for program expansion. Nebraska should look at investments to expand education capacity, such as simulated learning to supplement clinical learning. We need to look at compensation for preceptors and clinical agencies for the time required to support student learning. I thank the committee for your attention, and I'm happy to answer any questions.
Thank you very much. Questions? Seeing none, thank you.
Thank you.
Next testifier is Carrie Wade, President of the NNA.
Yesterday.
Yes, good morning. I
Good
was
morning.
here yesterday.
Yes, welcome back.
Thank you. Thank you, Chair Stinner and members of the Appropriations Committee. My name is Carrie Wade, K-A-R-I-W-A-D-E, and I'm a registered nurse and president of the Nebraska Nurses Association. I am here today to share policy solutions set forth by the American Nurses Association, the national affiliate to the Nebraska Nurses Association, to address the dire nurse staffing shortage crisis. Policy solutions recommended by the ANA to address the dire nurse staffing shortage crisis include to convene stakeholders to identify short and long-term solutions to staffing challenges, which could include identifying and maintaining the appropriate number and mix of nursing staff, as that's critical to the delivery of quality patient care and to preventing nurse burnout. Numerous studies reveal an association between higher levels of experienced registered nurse staffing and lower rates of adverse patient outcomes. Secondly, to remove unnecessary regulatory barriers to advanced practice registered nurse practice. Next, to provide retention and benefit incentives to retain skilled nurses. This could include enhanced compensation, scholarship for higher education, loan forgiveness, and family and wellness initiatives. To prioritize the mental health of nurses and other health professionals, and to provide additional resources, including recruitment programs and strategies to attract students to the nursing profession. These are nationally supported recommendations that align with much of what you've heard today from our local leaders and what I reviewed yesterday as part of the ARPA fund requests. Through collaboration of key stakeholders, nurse leaders, and funding resources to support such initiatives, Nebraska can serve as a leader for building the nursing workforce during this critical time. Thank you for the opportunity to be here again today and for having NNA as part of the conversation. I'm happy to answer any questions.
Yeah, tell me about unnecessary regulatory barriers. Could you give me examples?
Absolutely. So currently in Nebraska, 96% of our APRN workforce has their regulation barriers to practice to their full extent. However, 4% still have regulatory barriers in place that are preventing them to practicing to the full extent of their education.
Okay. Any additional questions? Seeing none, thank you.
All right, thank you.
Our next testifier is Amy, Health Center Association of Nebraska.
Good morning.
Good morning. It's good to see you.
You too. Again, not usually my face you see at this table. Chairman Stinner, members of the committee, my name is Amy Binke, A-M-Y-B-E-H-N-K-E, and I am the CEO of the Health Center Association of Nebraska. On behalf of the 7 federally qualified health centers in our state, HCAN is pleased to offer this testimony in response to LR 212. And we'd like to thank Senator McDonnell for introducing the study and for this committee for your ongoing commitment to strengthening Nebraska's healthcare infrastructure. Nebraska's health centers serve an incredibly diverse and complex patient population. Over 95% of our patients fall below 200% of the federal poverty level. 70% are of a racial or ethnic minority, and 45% of our patients are uninsured. Last year, Health Centers served over 107,000 Nebraskans across 72 service locations, providing primary medical, dental, and behavioral health service regardless of insurance status or ability to pay. Over the last 4 years, Nebraska's health centers have experienced a 27% increase in patients, nearly double that of the national average for health centers. This rapid increase in patient population resulted in a 37% increase in health center staffing. Health centers now employ over 1,000 Nebraskans, and yet we know that significant barriers to equitable access to care persist. According to the CDC, over 12% of Nebraskans have delayed or decided to forego care because of inability to pay, and over 20% of adults lack a usual source of care. Chief among those barriers to healthcare is health centers' ability to expand their workforce to meet ongoing need. Every single health center is actively recruiting staff for their existing locations, from the front desk to medical, dental, and behavioral health providers. In addition, there remains a significant need to expand access to affordable primary health care services, especially in our rural communities. But we cannot expand the health center footprint without adequate workforce to support that expansion. COVID-19 has only exacerbated workforce needs. In addition to existing staff being physically and emotionally exhausted, health centers are trying to balance routine patient care with the ongoing need to test, treat, and vaccinate against COVID-19. More recently, health centers have been struggling to fully expand testing in response to the renewed need because of an inability to find adequate staffing. It's evident that a permanent workforce solution needs to be in place because we know that the impact of COVID-19 will be far-reaching and ongoing for quite a while. In addition, in the last few years, Nebraska health centers have all but lost access to the National Health Service Corps Loan Repayment Program, a key recruitment tool for providers just entering practice. Health Professional Shortage Designation, or HPSA designations, use a complex scoring rubric to assign scores to eligible entities like health centers. Health centers rely on this program as a significant recruiting tool because they simply cannot afford large signing bonuses and significant increases in salaries. And changes at the federal level have really impacted rural states like Nebraska the most. This is why the work of this committee to expand the state loan repayment program has been so incredibly critical, and we're grateful for that work. As you all heard yesterday during the testimony regarding the distribution of ARPA funds, there are unique opportunities before us to address the workforce issues that impact every corner of healthcare in our state. Devoting resources to expanding pipeline programs, helping providers develop career ladder programs within their own organizations, housing for residency programs, and providing resources to support the retention of staff are all opportunities to support and expand Nebraska's healthcare workforce. At HCAN, we are currently developing a medical assistant apprenticeship program that will allow health centers to train existing staff within the four walls of their health center. This program will provide an opportunity for health centers to develop internal career ladders while affording staff the ability to earn while they learn. While this program is still in developmental stages, we have already received inquiries about expanding to include dental assistants and other entry and mid-level positions. In addition, we're exploring what would be needed to implement a health center residency program, especially in our rural health centers, that will allow health individuals to train where they eventually want to live and practice. We face a significant barrier and challenges when it comes to healthcare workforce shortages in our state, and we must all work together to identify opportunities to engage young Nebraskans, to develop training opportunities across the state, and to increase the healthcare footprint so it is accessible to all. Again, we would like to thank Senator McDonald and all the members of this committee for your ongoing commitment, and I'd be happy to answer any questions you may have.
Questions? Seeing none, thank you.
Thank you.
Next testifier is Terry Streetman, Nebraska Alzheimer's Association. Good morning.
Good morning. Hello, my name is Terry Streetman, spelled Terrystreetman. I'd like to thank Chair Stinner, Senator McDonald, and the committee for the opportunity to speak today. I'm the Director of Public Policy and Advocacy for the Alzheimer's Association Nebraska chapter. I'm here to talk about the dementia care workforce gap currently in Nebraska. 35,000 Nebraskans over 65 are currently living with Alzheimer's disease or a related dementia. Medicaid costs of caring for people with Alzheimer's in Nebraska were $372 million in 2020 alone. With the continued aging of Nebraska's population and the growth of the Alzheimer's epidemic, it is imperative on us to take action to ensure a dementia-capable workforce for the future. Within the healthcare workforce, direct care workers, that is CNAs, home health aides, and personal care aides, provide the vast majority of paid long-term care and personal assistance to the elderly, disabled, and those with chronic conditions in settings including residential care, hospitals, nursing facilities, and home and community-based settings. Research indicates that these direct care staff are the single most important determinant of quality dementia care. Data from BLS shows that 7.8 million direct care job openings will need to be filled nationwide by 2026. However, the labor pool for direct care workers is not keeping pace with the increased need, necessitating policy solutions to incentivize more workers to enter these fields. As you've heard, COVID-19 has only exacerbated the dementia care workforce gap in a field that serves our most vulnerable population to COVID-19. A report published January 2021 revealed 23% of nursing homes nationwide reported staffing shortages by early December of 2020. This report also identified Nebraska as one of 5 states with the highest rates of nurse shortages in nursing homes. As you've also heard, low reimbursement rates contribute to the inability to properly staff nursing and memory care facilities. The average per person Medicaid spending for seniors with dementia is 23 times higher than for those without dementia. And as we know, the rates do not reflect this difference. 3/4 of people with dementia will require admission to nursing homes by the age of 80, compared to only 4% of the general population. This workforce gap exists in more advanced levels of the field as well. Data indicates that there are only 57 total practicing geriatric specialists in Nebraska, only 17 of whom are located outside of Douglas County, indicating a very likely rural shortage. The UNO Center for Public Affairs Research projects that by 2035, people over 65 will represent more than a third of the population in our rural counties. Research projects that the demand for neurologists in Nebraska will exceed the supply by nearly 70% by the year 2025. Nebraska's state plan for Alzheimer's disease and related dementias recognizes the urgent need to build a dementia-capable workforce and recommends tuition reimbursement or student loan forgiveness incentives to encourage the expansion of our geriatric and dementia care workforce, especially in rural and underserved areas. We urge the unicameral to examine data on our dementia care workforce, to add geriatrics and neurology as approved medical specialties under the Rural Health Systems and Professional Incentive Act programs, and to make use of available funding from sources such as the American Rescue Plan Act for initiatives to develop Nebraska's dementia care workforce, including, as you've heard, expanding those incentive programs. Now is the time for us to ensure that our workforce is prepared to provide the level of care our seniors deserve. I thank you for your work on this important issue and would be happy to answer any questions. I also have provided additional references and comments in my printed materials.
Thank you very much. Questions? Questions, thank you.
Thank you.
You'd think out of this group, this aging group up here would ask a question. Our next testifier, Cindy Cadeby.
Good morning again.
Morning.
My
Good
name
to
is.
see you again.
It's been a short time. My name is Cindy Cadeby, CINDY KADAVY, here on behalf of Nebraska Healthcare Association, our 428 skilled nursing facilities and assisted living communities across the state. Thank you, Senator McDonald, for providing this opportunity to provide comments on the staffing challenges in long-term care and offer some suggestions about possible solutions. The handout in front of you includes some examples of data provided by the Nebraska Department of Labor. Some of them have been cited by previous testifiers. The Department of Labor projects that over the next 7 years, the need for healthcare support staff in Nebraska will increase by an average of almost 13%. This compares to the expected increase in all professions of just 5.5% growth. The need for nurses in long-term care has become so challenging that nursing facilities in some parts of our state are not able to admit an individual who requires 24-hour care by an RN because they just aren't available. This is despite offering higher wages, bonuses, and using staffing agencies. This situation only contributes to challenges with hospital capacity when hospital patients cannot be discharged because the nursing facility does not have enough staff or does not have the necessary level of staffing expertise to provide the care for the individual. A recent national studies indicated that 58% of nursing facilities are currently limiting admissions due to staffing. Also, according to the Department of Labor in Nebraska, nursing facilities pay the highest wages for healthcare aides and for LPNs, and some of the highest wages for RNs. But still, the struggle is there to find those necessary healthcare workers. Also, recently, in crisis situations, ICAP, which is the infection control team at the UNMC, is directing long-term care facilities to allow COVID-positive staff without symptoms to care for COVID-positive residents because there just isn't anyone else to provide that care. A recent survey of nursing facility and assisted living providers conducted by our association and Leading Age indicated that 81% of facilities are currently relying on staffing agencies, and that there has been a significant increase in the cost of staff following the pandemic. The Department of Labor indicated there were advertisements for more than 3,000 openings for RNs in Nebraska this week, with a significant number of advertisements for LPNs and nurse aides. We are grateful that the governor took action through executive orders to waive some of the regulations that allowed things to happen like retired nurses to come back into the workforce and to allow the temporary use of nurse aides and medication aides that used on-the-job training versus classroom hours in order to learn how to care for individuals. This resulted in approximately 2,000 additional nurse aides and medication aides being available to care for people in long-term care facilities. We'd be glad to work with the legislature to identify ways to capitalize on this interest in working in healthcare through some of the things that are identified in your handouts. That was amazing to us that we saw that many people come into the workforce just because they didn't have to go to the classroom for 75 hours before they could actually go into the facility. So instead, they were allowed to have on-the-job training, online training, and nurse supervision to ensure they were competent to provide that care. That brought a number of people into this field. So we'd like to follow up on this. That's what I have. Thank you for your time.
Thank you. Questions? Senator Colderman.
Cindy, thank you for coming today. My question deals with the licensing regulation. You just alluded to the fact that you took away some regulations and instantly we picked up a couple thousand employees. Do you know, is there a backlog when somebody graduates from a school, like whether it's Kearney or Scottsbluff or UNMC or wherever, between that time and the time, is there a backlog of getting the license accepted and getting them licensed to get into the workforce? Is there a challenge there?
There can be. I know the department invested some money into an online licensing system that's supposed to help with some of that. For our nurse aides and medication aides, that can be a barrier. They're not licensed, but they're on a registry, and it can take a significant amount of time at times to be able to get onto the registry and be able to actually provide care. It seems to vary.
But the executive order helped.
It did help because right now, by regulations, for example, nurse aides have to have 76 hours of classroom education. So It's kind of an archaic way to look at training based on hours versus competency, but that's the way it is in the regulations. So this allowed, this waived those classroom hours so that those individuals could start providing care as soon as they were determined by the nurse to be competent to provide that care.
Thank you.
Do they provide the classroom hours online?
There are some programs that will do that, yes.
Okay.
Or a combination sometimes of in-person and online.
Very good. Any additional questions? Seeing none, thank you. The last testifier, come on up. Topher Hansen. Kind of like a game show.
It's quite a title.
Good to see you again.
Good to see you again. Thank you. So I am, excuse me, standing in for Annette Dubas today, which is listed on the actual testimony. And so I won't try and be Annette. I can't rise to that level, but I'll get the job done. So Senator Stinner, thank you for your leadership, and members of the committee, thank you for doing this. My name is Topher Hansen, Topherhansen, and I am the president and CEO of CenterPoint, which is in Lincoln and Omaha, but serves every single region in the state in terms of people that have mental health, substance, and primary care issues. And I come here today on behalf of NABHO, the Nebraska Association of Behavioral Health Organizations, which is over 50 members that include hospitals, consumers, providers, and the regional governing authority. A very unique organization across the country. Not another one exists like Nebraska's, of course, because we're Nebraskans, right? So NABHO is in the business of advocating for behavioral health. And what we say is there is no health without mental health and substance care. And so it's a whole body kind of issue. So we need to address all that. The workforce shortages we are seeing are dramatic. I'm going to give you examples of what I know, which is CenterPoint. We serve 4,269 people last fiscal year, and that's 1,000 more than we served the prior fiscal year. And yet we're at about a 60% staffing issue right now, 60 to 70%. And the nursing shortage that we see in particular, and by the way, we support all that's been said here. We understand the same experience. Our nursing, we have about a dozen nurses throughout our programming. We have about 40 programs, and we have about a dozen nurses covering those programs, and we're at about 60%. So more people coming in the door, less staff, and the primary issue that we hear is just what you heard before me, which is stress and over the top with demand and stress and inability to feel like they can do the job and do it well and be satisfied at the end of the day. So dealing with all that in terms of retaining staff, so those that are there, and we set up systems. We have conversations about this weekly, about what can we do to build culture and to build the experience, have people feel like they can remain here and be in a happy place to work, which is one of the high priorities for anybody in a work situation. Do I like working in the place that I am? And we try to build that experience. The issue that we deal with mostly right now is the wages. The wages are going way up on everybody, not just on nurses, but on our entry level, which we refer to as behavioral health technicians. So we have jumped our wages up to $14.50 an hour to try and be in the marketplace for the Targets and the McDonald's and the other entry-level places that people might go just to be competitive. And even that barely got a tick on the scale that we have enticed some more, but it's still a challenge for us. So we're working to retain people and do different programs, the loan repayment program and wages and other cultural kinds of things we can do internally, but we need to boost this up and figure out the ways to not only retain them, but recruit them in the first place. We have to be attractive in the marketplace. So NABO has done a study with Beacon Behavioral Health Education Center in Nebraska. And what we know is that 81 of the 93 counties are federally designated as workforce shortage, and 33 of the counties have no behavioral health provider of any kind, none. And not only that, but our workforce in the behavioral health world is aging, and so we're worried about replacement. What we know from a survey that we did with Beacon is 84% of the respondents reported an increase in the severity of the issues we're seeing. So not only numbers, but the severity has increased. 85% reported the stress level within organizations is higher than pre-COVID. 65 are seeing more vacancies, and 77% say those vacancies are limiting the capacity to serve. We have a 20-bed program in Omaha that is not open because we don't have staff to operate it. And there's over 100 people standing in line for that program. That this is really, the majority of people are saying this is moving to a crisis level, not a shortage level. So with my time out, the last thing, if I may, is we really appreciate the work you have done to increase rates over the last year. That has been one step forward, and now we've taken 2 steps back with having to increase our wages. We need to look at the costs again and try and get the rates that we can get paid for the price of business. And COVID has really changed that. So with that, I'll stop and say thank you.
So you've indicated there was an increase in patients that have come in over 1,000.
Just at Centerpoint.
Just at your place. But tell me, can you give me an idea? Was that due to COVID, or was there other problems that you
so COVID really, in our world, COVID exacerbated everything. It didn't as much in the larger world. As I've said, from COVID, everyone understands they have mental health. The question is what condition it is in. In our world, so of the 4,269 people we saw, 60% made less than $1,000 a year, or nothing, basically. So we have a very defined population, but what we've seen is that grow, and then and all their conditions exacerbated. So the substance use is up, the mental health issues are up. Just on anxiety and depression, the mention of those, that being an issue has grown almost 300% because of the environmental issues that have exacerbated all that is there. So the acuity is up, as you've heard previously, and then the numbers are up. And I'm not in a circle of people where mental health does not come up as a conversation about anxiety, depression as being the primary two. And then the substance use. We've seen alcohol sales go up 600%, and then more substances beyond that. So it's it just amped everything up.
I'm just trying to get a gauge on, is this a temporary increase and we go back down to a normal?
It's a great question.
Or is
I
this
wish
going
I
to
knew.
persist?
Okay. Yeah, my crystal ball is a little foggy. I couldn't bring it today. So.
Mine's never worked. So
I did, as of January of this year, I did not see this coming. We did not think we were going to get hit by that. And by the end of the first quarter, we were starting to see it. And then it's really just grown and grown and grown. So
it's all the way across the state.
Yeah, it is.
Senator Clements.
Mr. Chairman. Thank you, Mr. Hanson. When you're talking about provider rates, can you say what your mix of Medicaid and private pay percentages are?
Well, for Centerpoint, again, as you heard, 60% of the people that we serve make less than $1,000 a year, and virtually every person we serve is in the poverty range. And so we are mostly from services rendered Medicaid connected. We were a mix of regional behavioral health funding and Medicaid, but with Medicaid expansion, most, probably 80%
of our funding comes from Medicaid, and then some regional behavioral health authority money and some private insurance. And then we do a lot of housing and some veterans programming too, so we get funding from those sources. But for the services rendered on a fee-for-service basis, it tends to be mostly Medicaid with some regional money.
All right, thank you.
Yep, you bet.
Additional questions? Seeing none, thank you.
Thank you.
Senator McDonald.
I'd like to take a moment to thank everyone that testified. Someone that could not testify today just based on the number of people we've had testify, and she's here today, is Margaret Begley. Margaret works for the Creighton University School of Nursing, and she's been helping out in my office as she works on her doctorate. And she's been extremely helpful, and she's going to be helpful to this committee going forward. As Andy Hale testified, he said, we have, they're meeting, a number of them, these experts, monthly, and ideas are on their way. And in January, and he's going to have that calculation of those ideas in December, and for us to look at. Now, we know this is a major problem, and it's not going to be solved overnight, but I think we can take a major step forward to help in January. And again, not solving the whole problem, but how do you eat an elephant? You eat one bite at a time. And I think that's how we have to approach this, but we do have the opportunity. We know that the problem exists. We know that these subject matter experts are going to help us solve this problem. And I'm looking forward to taking that major step in January and helping these people that are taking care of our communities.
Thank you. Any questions? Seeing none, thank you very much.
Thank you.
That concludes our hearing on LR 212. I'll now open the hearing on LR 210. Senator McKinney.
One bite
You
at a
don't look
time.
like Senator McKinney. Just a second.
His loss is our gain. So.
One more time.
We'll just let the room clear so you'll have a chance to speak. I do not have a list of testifiers, so I'll just wing it. We'll work from there across the room if that's okay.
No, that is totally fine. Here in verbal in-person testimony, we have Attorney Spike Eichhold on behalf of ACLU and Jasmine Harris on behalf of RISE. And there was some written testimony for some testifiers who couldn't make it. So Appleseed and James Davis from the Ombudsman's office.
Okay, you may begin.
Good morning, or afternoon now, probably. My name is Dominique Johnson. That's D as in Daisy, O-M-I-N-I-Q-U-E. Last name Johnson, J-O-H-N-S-O-N. I serve as the legislative aide in the office of Senator Terrell McKinney. Senator McKinney is traveling and is en route to Nebraska. His plane got delayed this morning, so he sends his apologies. Where we work on behalf of Legislative District 11, which is comprised of North Omaha. I am a North Omaha native. I'm a proud graduate of Omaha Public Schools and proud to say that I am a product of a wonderful village who raised me into the woman I am today. North Omaha is full of upstanding residents, rich history, and culture that is invaluable. I would be remiss, however, if I perpetuated the notion that I didn't understand even as a child when I didn't have the verbiage to quite explain the feeling that North Omaha is a perpetually underserved, underfunded, undervalued, and underutilized part of Omaha and within the state of Nebraska. The commitment the state of Nebraska has dedicated to the sustainability of North Omaha and its residents has been next to non-existent. The result of this inaction has resulted in more than half of the residents and families living below the poverty line, and with poverty having a strong correlation to crime, has resulted in a disproportionate amount of individuals from North Omaha being incarcerated or being affected by the criminal justice system. Over the summer, Senator McKinney visited multiple prisons and community corrections facilities across our state. The one constant was the amount of individuals that he knew or crossed paths with who called North Omaha home. Although Black people are disproportionately represented, the reality spans across racial lines. Instead of a war on poverty, our elected officials decided to pursue a war on drugs or proclaim to be tough on crime. These two approaches failed not only in theory, but also in practice. Instead of making an example for the greater public and merely encouraging individuals to just say no, the result ended up being high rates of incarceration of many individuals who were poor and struggling or dealing with serious mental illness. To provide some clarity and included in the handout provided, we can see the poverty rate of North Omaha juxtaposed to other budgets within the city. The poverty rate in North Omaha from 1991 was 34%, and in 2019, it was 33.5%. The budget for the Nebraska Department of Correction System was $55,640,919 in 1991. The budget in 2021 is $220,562,435. The budget for the Omaha Police Department in 1991 was around $31 million, and the current budget is over $164 million. The 30-year average poverty rate for North Omaha is roughly 36%. The 30-year average budget for the Nebraska Department of Corrections is $145 million. The 34-year average budget for the Omaha Police Department, OPD, is $164,584,331. The 10-year average poverty rate for North Omaha is 38%. The 10-year average budget for the Department of Corrections is over $200 million. And the 10-year average budget for Omaha Police Department is $135 million. Bearing these truths in mind, it shouldn't come as a surprise to anyone why Senator McKinney is a staunch opponent to building a new prison when other avenues of addressing the root causes of crime and incarceration in our state have yet to be explored with true intention or purpose. At what point do we deem it necessary to shift our way of thinking, our strategy, our overall approach to the well-being of our residents? The current state of our criminal justice system and prison system in Nebraska as it stands is embarrassing. And while we recognize that money isn't the ultimate problem solver for everything, we believe that fiscal resources can address a great deal. Decreasing poverty and ensuring that individuals and families have what they need to be stable should be priority and not an afterthought for our state, and especially for North Omaha. I opened my statement by mentioning the rich history and the wonderful village of residents of North Omaha that raised both myself, Senator McKinney, and Michael Lee, the admin aide within our office. I'm going to close my statement the same way, because whenever conversations arise regarding the many inequities present in North Omaha, it somehow turns into a conversation of lazy people and people not doing enough to pull themselves up by their bootstraps, or those bad people in North Omaha. It's clear even in the redistricting debates when other legislative districts fight to the death not to be considered part of Douglas County. It may help if we work to shift the lens in which we view North Omaha and its residents. North Omaha may be a far cry from its full potential. It may not have the full luster of when Preston Love Sr. would play ballrooms with the Count Basie Orchestra, or when Earl Little, the father of Malcolm X, was preaching on 24th and Lake. But that is the spirit of the place we call home, and it is a place most deserving of equitable investment. Thank you, and I welcome any questions.
Thank you. Questions? Seeing none, thank you.
Okay.
And are you going to have concluding comments?
Senator McKinney is on his way. Hopefully he beats me before closing, but if not, I will probably briefly close.
Very good. Good morning.
Good morning, Senator Skinner and senators of the Appropriations Committee. Let me take this off so you can hear me. My name is Jasmine Harris. That's JasmineHarris. I am the Director of Public Policy and Advocacy for RISE. I want to thank Senator McKinney for introducing this resolution today. And I request that this testimony be included as part of the public hearing record that shows RISE is in support of LR 210. RISE is a nonprofit who works with people that are currently informally incarcerated. We run a 6-month program that focuses on employment readiness, character development, and entrepreneurship. We serve people incarcerated at 7 of the Nebraska correctional facilities with this program and offer reentry case management services as people return home. We have now expanded to include a family program and a business academy for individuals who are starting businesses. If we look at the approved budget for the Department of Corrections for 2021 to 2022, came out of this committee, $245,026,442. And if we look at the average daily prison population that the department reported, 5,322 persons, it costs a little over $46,000 per person to incarcerate people here in Nebraska. This number continues to increase as the cost of goods and services rise, more staff added, salaries adjusted, capital additions and improvements continue. This number continues to rise because we see more people coming in and returning to this system. In order to decrease the number of people incarcerated and the costs associated with incarceration, we must look at other alternatives. My educational and professional background is in public health. I'm sad to see all of my health people leave. The main focus is prevention. Incarceration has been determined to be a public health crisis. This falls right into the idea of the public health crisis zones that you heard about earlier that Senator McDonald introduced. What we need to do is build up and fund our public health infrastructure, and that way we can address these matters. What is going on in Nebraska? We must take a preventative approach. In order for that to happen, we must look at how we appropriate funds in this state and reinvest these dollars into proven strategies that work. One of the strategies falls under primary prevention, which is to address the conditions of poverty. According to research in academia, poverty is a contributing factor and a result of incarceration. Voices for Children in Nebraska's 2020 Kids Count report states that in 2019, 10.5% of Nebraska's families lived in poverty. But what was really eye-opening was the breakdown of overall poverty rate by race. 31% American Alaskan Natives, 27% Black and African American, 22% Hispanic Latino, 9% white, which draws an eerie comparison with the rates of individuals incarcerated broken down by race. So how do we address these conditions of poverty, Jasmine? I'm glad all you senators just asked me that. Reinvest funding into environmental and system improvements, policy that focus on the social determinants of health. This includes things like economic stability through employment. Incarceration reduces annual earnings by 40% for men, which impacts family poverty. This doesn't even touch the income gap between men and women, where we know the majority of women who have been incarcerated were the main caregivers and providers for their families and households. What do we need to do? Increase minimum wage and close the income gap. Neighborhood and built environments through addressing affordable housing. In Omaha, 45% of renters are overpaying on their housing. What that means is they're paying more than 30% of their budget for their housing costs. This does not include the quality and quantity of housing that we have in our state. If we look at the infrastructure of communities that people are returning to after incarceration, majority of them are socially disorganized. And these people are returning to these because they are forced there, because they have nowhere else to go, because they can't afford anywhere else to be. That impacts recidivism. Other things you can put money into: education, access, and quality by funding early childhood education initiatives, higher education access, and vocational skills training. We just heard from the healthcare systems and people here. Healthcare and quality, which includes access to mental and behavioral health and substance use services. The behavioral health aid budget for 2021 and 2022 was $77,956,716. That pales in comparison to the amount that NDCS is receiving, which is staunch because upwards of 60% of incarcerated individuals present with some form of mental health or substance use disorder. Bolstering access to these services pre, during, and post-incarceration will make an impact. And while speaking of an impact, most people understand programmatic impact. Another promising strategy is a model for social impact investment or bonds. These investments are public-private partnerships, and the state pays for the success of social improvement initiatives. So for example, instead of programs being operated and facilitated by the Department of Corrections, organizations like RISE with a proven record of success would receive access to the investment funds to provide better outcomes. I heard the other day that if correction departments were analyzed like any other business or organization, it would be shut down, surely based on the abysmal return on investment that it has. We know that incarceration is not the answer to the problems that we continue to see. We have to start approaching this public health crisis with a new outlook on how we reinvest funding to address conditions that contribute to the incarceration rate. Addressing poverty through preventative strategies is the most sensible and effective way to decrease our problems with incarceration in Nebraska. The age-old adage is an ounce of prevention is worth a pound of cure. With that stated, RISE supports LR 210 and asks that the committee members seriously consider the information and recommendations that are brought forth in this hearing, along with the Nebraska Justice Reinvestment Initiative, to pursue legislation that will alleviate the connections between poverty and incarceration here in Nebraska. I'm happy to answer any questions and can forward any links to all of the articles and data that I mentioned in my testimony today.
Very good. Question, Senator Coulterman, then Senator Vargas.
Thank you, Senator Stinner. Ms. Harris, thank you for coming. RISE, you're the Chief Executive Officer of RISE.
I'm the Director of Policy and Advocacy.
Okay, so how long has RISE been around?
We started in facilities in Nebraska in 2016 as part of a national organization called Defy Ventures, and we broke off and rebranded as RISE in 2019, roughly beginning of 2019.
And give us some examples of some of the successes that you have had in, I assume it's primarily in North Omaha?
No, we're in 7 of the correctional facilities. So we've graduated over 400 individuals from the Department of Correction with our program. We offer things like business pitch competition inside where people pitch their businesses that they come up with, and they have IOUs of funding that can go towards their reentry services or if they want to start their business when they get out. Just this past year in 2020, we have served over 150 individuals with reentry services. We created a reentry emergency fund. So individuals who are struggling with paying rent, getting to their jobs, getting Pampers for their children, we have that as a reentry emergency fund that we help individuals with.
So you're a programming agency inside the Department of Corrections or as a volunteer group inside the Department of Corrections?
Yes, and this year we was our first year receiving the vocational life skill grant from the Department of Corrections.
And how many people do you have working in your organization?
We have 21 employees.
And they're all full-time paid employees?
Yes.
And they go right into the Department of Corrections and work with people?
Not everybody is in the facilities full-time. We do have what we call program associates who go in. So an associate will have maybe 2 facilities that they operate the program in. With COVID, it has been altered. With the staffing shortage, things have been kind of a little wonky, but we have actual program associates who go in and facilitate the program. We do have reentry specialists who then work with individuals about 6 months prior to their release. So that way we have a continuity of working with them while they're still incarcerated, working on their reentry plan, and then still providing services once they come out.
So is it fair to say that your programming model works in conjunction with the Department of Corrections, but it's programming that's above and beyond what the Department of Corrections would offer?
I would say yes.
All right, thank you.
Thank you.
Senator Vargas.
Thank you very much for being here, Ms. Harris. It's good to see you.
Good to see you.
So I have a question and then sort of like an ask from you. So the one question is, have you seen social investment bonds in this capacity work in other areas? I mean, it's a big word. The way I see it is it's more of we're like basically contracting out work that can be done better by an outside entity. In this instance, it could be a nonprofit like yourself. So where has this been done and where have you seen this done?
Yeah, there are different places that are doing them for different initiatives. So there is Utah, who's doing a workforce development social impact bond. DC is doing their water green infrastructure improvements through a social impact bond. And Central Maryland is doing their kind of Meals on Wheels, which is an extension meeting with the aging population in their home, getting them to talk more, figure out what they need and things like that, versus them all being at the facilities and things like that. And then Australia has also started putting social impact bonds in place.
Way to go, Australia. Okay. And then
UK, all the other countries.
The other thing is more of like an ask push to even the committee is, if you haven't been to our prisons, it's going to be very eye-opening to you. I had this conversation with Senator McKinney. I remember visiting many of the prisons. Tecumseh is the one that comes to most to light. I remember going to their classrooms. Nobody was in their classrooms at that time because they couldn't staff the supervisors at that time, which means that the inmates were sort of confined in one space or one area, couldn't do educational activity simply because they didn't have the sergeants or corporals to then be able to do supervision in those classrooms. So there are I don't like calling them low-hanging fruit, basic things that we need to address, and that's sort of the staffing shortages. So it will be eye-opening if you go and see. And I also remember going to the solitary confinement wing. I've talked with ACLU about this. It is a disproportionate Black and brown communities there. So it's an ask to everybody. And my ask to you is, we had our ARPA funds conversation yesterday. It was abundantly clear that we are missing out on how you talk about social determinants. What are recommendations? You don't have to answer this now. It's more of an ask down the line here. Recommendations from your perspective on how we can do more of the social determinants, one-time use of these ARPA funds to address these inequities before they even happen. You talked about the justice reinvestment, which I'm a big supporter of, but I would just want to make sure that Rise, your voice, and other voices, and this is also for Senator McKinney's office, we were missing different voices in that conversation, and it's important that we don't miss them here in the process. That's just from my perspective. I think it'll help the Appropriations Committee in the long term.
Okay.
Senator
Thank
Dorn.
you, Chairman. Senator, thank you very much for being here today. Very, very informative. But I guess I'm still trying to understand. You've mentioned your funding comes from grants and stuff like that. Do you get any from the Department of Corrections or any from Department of Health and Human Services?
Department of Corrections, we are a recipient of the Vocational Life Skills grant, and this was our first year receiving it. 82% of our funding comes from private foundations.
Private foundations, but outside of that grant from the Department of Corrections, you're not receiving what I call state help.
No.
Okay. Well, thank you. Amazing. Yep.
Welcome. Senator McKinney just came in. Any additional questions? Seeing none, thank you very much.
Thank you.
Good afternoon.
Good afternoon.
Thought I'd be polite, let Ms. Harris go first, but I wish I wouldn't have done that because she was very good. So she's tough to follow. My name is Spike.
That is tough to follow.
My name is Spike Eicholt. First name is Spike. Last name is EICKHOLT. Appearing on behalf of the ACLU Nebraska, testifying in support of LR 210. We want to thank Senator McKinney and his office for introducing this resolution. As you've heard from the previous testifiers, there is a correlation between poverty and crime. And that does not mean that poor people are more likely to commit crimes. But what it means is that the factors that contribute to criminal acts, to criminality and criminal behavior, are more prevalent among people who are poor. Factors such as substance abuse problems, undiagnosed and untreated mental health issues, modeling behavior when children are young. If they have adults in their environment, immediate environment, that are in the criminal justice system, are more likely to end up in the criminal justice system. Various developmental issues such as asocial behaviors or impulse control. All of these factors that go into why people commit crimes are just more widespread and more prevalent among the poor. That's just a fact. That's just a reality. And I've got some citations in the letter I submitted to you that I'd ask to be included as part of the record, please, that you can also look those up as well. Another factor or another consequence of being poor is that when people who are below poverty end up in the criminal justice system, they are more likely to be arrested, the more likely to have serious charges, the more likely to be jailed, the more likely to be imprisoned. And then when they do get out of prison, just like anyone coming out of prison, they're going to have that additional barrier to earning a higher income. I mention this because incarceration costs the state money, as this committee is well aware, and poverty therefore costs the state money. And the most expensive sort of example of what being poor in this state costs the taxpayers and this government is incarceration. $40-some thousand a year to house somebody in prison is the most. You're providing everything. You're providing food, you're providing mental health care, you're providing physical health care, you're providing everything that you can for people. It's direct care, and it's the most expensive one. This committee is well aware, and we've argued before, that this state and the legislature has paid a significant amount of money on incarceration costs. And you've heard some of the statistics mentioned earlier, but the rate that we spend in our prisons, as Open Sky references in their report from last year, has outpaced the rate of other government agencies and the overall government budget itself. So where do we spend the money instead? And as you heard what Ms. Harris said, she gave some good examples. You spend money on reducing crime and reducing poverty. And those can be simple things that you've heard talked about before, as paid family medical leave act laws, providing for increased minimum wage, providing for childhood assistance, those kinds of things that provide for stability and ensuring that people are going to have at least a leg up, if you will, when they are living before they end up in the criminal justice system. I would submit that Nebraska support this. Last year, when there was talk about the new prison, the ACLU commissioned a poll, and I've got the statistics on page 5 of my letter, but I just want to read a couple of those out to you. During the poll that we had commissioned, and there's a link to it, when Nebraskans from all political spectrums, all sort of walks of life were contacted, 62% of the respondents, without any prior context, said that it was important or very important to reduce the number of people in prison today. 68% of the respondents said that they are concerned about too much taxpayer money being proposed to fund a private company building a prison in Nebraska. Senator Vargas mentioned this earlier. You heard from, I think, 40 some, maybe close to 50 different groups and individuals yesterday about this once in a lifetime opportunity, or whatever the phrase that people kept using on to spend money on. No one asked for a prison. No one came here and says, build us a prison. This is what we want. They asked for other things, alternative, that would relate and would contribute to recidivism being reduced. And that are things like housing assistance, mental health care, early childhood care, those kinds of things. So we would submit that the taxpayers and Nebraskans don't want a prison. They want alternatives to prisons. And like Ms. Harris said, there are some. The CJI group is looking at some of those now for sentencing structure changes, maybe some different ways of changing the laws to be a little smarter on crime and that kind of thing. I just want to, before I run out of time, I'm getting distracted with the time, even though I testify all the time by the clock. This committee's done some very good things. When you funnel the mental health court, the drug court things, that works. And it's more than just getting an additional judge to hear the cases. Poor people can't pay for a drug and alcohol evaluation to show that they got a drug problem to get in a drug court. But the drug court funding that you provides that assistance. If somebody's going to succeed in drug court, somebody working for the drug court program is going to have to do home visits at 10:30 on Friday night to make sure that they're home when they say they're home. And that's the kind of assistance that you have, that diverse people from the criminal justice system, and it's got a better outcome in the long term. That's just an example of something that we've done right. I'll answer any questions if you have any.
Have you followed the mental health court that we set up? Is that up and running? And what's the result so far?
I don't know if it's up and running yet. I had one of the first graduates of similar veterans treatment court here in Lancaster County, and that's going very well. Because as you heard, I think Ms. Harris said the statistic that she mentioned, something like up to 60% of the people who are in prison have a diagnosed mental health issue of some degree. I did attend, this is not really an answer to your question, but one thing that I want to mention to this committee, during the special session, Senator Lathrop and the Judiciary Committee had a listening session for staff at the Department of Corrections, because as you probably know, one of the costs that we just can't seem to get ahead of is paying to staff the existing prisons that we have right now. I was really struck when I heard all the different staff people talk, because they were asked by Senator McKinney directly, what would help, would a new prison help? Most of the time they didn't say a new prison would make any difference. If they did, they qualified it with, first we have to get the existing staffing level up. But one of the things that really sort of struck me as surprising was the number of staff people who said, we need to have programming available in the prison. These inmates they have too much time on their hands. They're getting out worse than when they came in. I mean, your model for corrections ought to be, you take somebody off the street, you lock them up for a couple of years, let them cool off. You try to teach them something, hope they don't come back. And when they leave, they ought to be better than when they went in. And just like Senator Vargas says, when you tour these facilities and you got empty classrooms, those guys are not learning their GED. They're not getting their GED. They're not learning a trade. They're coming out with the general hope they're not going to get caught again. And that's why our recidivism is ticking back up than it was just a few years ago.
Any additional questions? Seeing none, thank you.
I'll go ahead and close briefly since Senator McKinney just got here. I don't want to throw him in the middle of the question.
You realize Senator McKinney's here.
Yes. I didn't want to throw him to the questions just because this is a short closing that I wrote for him. When you got here.
We'll let you talk after her. How's that?
As Jasmine and Spike mentioned, and Spike being with ACLU can probably mention this a little bit better than me. When I worked for both Iowa Legal Aid and ACLU, there was an analogy that was given to me by my supervisor. Iowa Legal Aid is usually there to assist people who are actively drowning, right? Like you have an immediate problem, you're about to get thrown out of your apartment, you need help. ACLU was there for the more longstanding issues to figure out, why do people keep drowning? What is the issue here? And they is more the long haul constitutional rights, things that you can get all the way to the Supreme Court. And I think that can be applicable to more than just working for ACLU and Iowa Legal Aid. What is the reason why poverty is so high within North Omaha and Douglas County, and why are incarceration rates so high? So instead of throwing money from appropriations to DHHS for additional TANF monies, for additional, monies for low-income families, why don't we alleviate the issues altogether and then use our imagination to think, okay, if we alleviate those issues, what money can appropriations throw to programming? What can we do to decrease the people's issues altogether? And so again, I would just reiterate what I closed in my opening, is that the spirit of the place we all call home is a place most deserving of equitable investment. Thank you for your time.
Thank you. Senator McKinney, it's good to see you.
Good to see y'all as well. Sorry for my tardiness. I was in Minneapolis for Build and just got back. Thank you, Dominique, and thank you,
How'd
Mike.
you like Build, by the way?
It was good. It was a good experience. And I don't got much else to say. I would just say that our state has a unique opportunity to not only address mass incarceration, but also address poverty at a great scale. And I think once we go into the next session, we need to keep that in mind. I know I've heard other proposals that individuals are working on across the state, but I think one of the biggest proposals that we as a body should take care of is addressing poverty and decreasing poverty, not only just in North Omaha, but in South Omaha and also in our rural areas, because it's most important for the viability of our state as we move forward. We can't grow our state if we have so many individuals living in poverty and in and out of jail so much. And as Dominique stated, I visited multiple facilities throughout the interim, and the common theme was I either knew this person, went to school with this person, and also knew these individuals grew up poor or in the foster care system or things like that. And I think we have to think about that when we think about building another prison. It really doesn't make any sense to invest $230 million and not even account for the operational costs to put that amount of money into brick and mortar facilities and not put those same resources into people. Just imagine if we put $500 million into addressing poverty and decreasing poverty. I could almost guarantee you that would go a long way with not only decreasing our crime rates or our prison population, but just the overall morale and sustainability of our state. We have to look to the future and think about how can we grow Nebraska. I don't think you grow Nebraska by investing in prisons. I think you grow Nebraska by investing in our people, making sure our kids have adequate education, make sure they got a good amount of food to eat at night, proper housing, affordable housing, transportation, things like that. So the reason for this is to really look at it and make sure that once we get back in January, there is a proposal on the table or proposals on the table, not to build another prison, but to invest in the people of this state. Because in my honest opinion, especially for me as somebody that grew up in an area of high poverty, this state didn't take care of us. And luckily, myself and my staff and Jasmine, we're here today to speak about it. But I know so many other people that were killed or locked up for the rest of their lives. And I just never viewed it as fair. I don't think we ever got a fair shot at seeing what the good life was really about in this state. Thank you.
Thank you. Questions? Seeing none, thank you.
No problem.
And that concludes our hearing on LR 210, and that concludes our hearings for today.